Hello, 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 my friends. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. It is Sunday, September 20th. Time is going by so quickly. It's absolutely amazing. It is time to do another live IC support group meeting. Hello. Oh, Allison is in pain. Allison, let's see what we can do to help you. Hey, man, girl, you caught in early. Tell me about your pain. So the purpose in doing these meetings is to make you so strong, so knowledgeable, so informed that no one can mess with you again, that nobody can tell you that this is all in your head, that nobody can demean you or diminish you or refuse care. Let's see. Uh-oh. My job is to educate you. My job is to give you new resources. My job is to help you try to understand that what you think might be IC might not be IC, that there could be something else going on. Remember, sometimes the bladder is a secondary victim of other things happening in your pelvis. And so if you've spent 10 years doing bladder therapies and you're not better, hey, what do you have to lose? What do you have to lose? So I have a lot to do today, and you know what? I have a new little, hopefully quiet. I gotta turn that on. Air conditioner, because it always gets hot in here whenever I do these. So we're gonna do. Let me introduce myself. Jill Osborne, president and founder of the Interstitial Cystitis Network. I am the longest-serving support group leader in the United States, 27 years and counting. I am the national IC support group leader. Hello, Donna. Nice to see you. I bring to you 3 college degrees. I've got a degree in chemistry. I've got a degree in pharmacology, drug development. I've got a master's degree in psychology because I turned out I didn't really like the lab work very much. Changed direction, and bam, I was a presidential fellow. Life was looking great, and then all of a sudden, guess what? It happened to me. I had bladder pain for the first time. I'd had other issues before then, but literally overnight, I could not do what I should have been able to do. It's stunning. Then literally in hours, your life changes forever. And for me, it was a swimming pool accident. The pool made a massive mistake with their chemicals. I swam and swallowed massive levels of acid, woke up with what was diagnosed as chemical cystitis. I endured a chemical injury to my bladder, which created my foundation for bladder pain. And, the rest is history. The rest is history. So the IC Network, our website, icnetwork.org, has been rated the most accurate, reliable website on IC. It was my doctoral dissertation proposal for bringing support to patients who were homebound, because I was indeed homebound. So if you haven't been over to our website, icnetwork.org, I encourage you to do so, because you're going to find a lot of really good, solid information. Look at that. A door is open. Hold on a second. There we go. So, normally the way we do these meetings is I do about a 30-minute little intro, education lecture, something at all like that. And then we take your questions, and then we move over to Zoom so that y'all can get some personalized coaching and have an opportunity to talk to me and talk to everybody else. And then generally we come back to Facebook. Now I will tell you, I have been working on editing this new IC book. I worked on it for hours yesterday, hurting my back. So we'll see how long I last. It is also smoky again. So for those of you who don't know, we are in California. We have been surrounded by fires. The nearest fire is about 100 miles away, but the smoke has turned. So if things start turning orange and gray, it's the smoke. We are safe for the moment. Before I get started, and Allison was the very first person in this room. She said she's in pain. Post to plan B, flared me right up like nobody's business. So actually, before I start my intro, I want to hear a little bit from Allison here. So Allison, so we're simulcasting. We're simulcasting on Facebook, YouTube. If I'm looking up here, I'm looking at Facebook. If I'm looking down here, I'm looking at YouTube. Let me switch my computer here around here. Hello, Michelle on YouTube. It's nice to see you. Hello, Shannon. Shannon says, I'm super excited. I've been pain-free for 11 weeks now. Yeah, baby, I love it. What do you think did it for you? Peggy says, hello from Fort Knox, Kentucky. Hi, Peggy. DJ says, I'm in such a flare. I have a hydrodistension tomorrow. Oh, okay. And the purpose of the hydrodistension is what? What are you hoping to accomplish out of the hydro? Hello, Kathy, Debbie. Holy crap, everybody. What are you all flaring today? Like, holy moly. What does everyone recommend? Debbie, it begins with understanding what type of flare you're having, hon, because there are different types of flares. You can have a bladder wall flare from drinking something, eating something you shouldn't have done, or you could have a pelvic floor flare from sitting in a car for a long period of time, having sex. And so kind of the question we look for is, when is your pain the worst, before you pee or after you're done peeing? That's an important question here. Tabitha says, it's been a rough week going through physical therapy. I believe it will help though. Yeah, Tabitha, when they first start working with those muscles, they're going to be tender. If you've got tight pelvic floor muscles and they've been tight for a long period of time, yeah, they're going to be tender. Hi, Deborah. Hi, Shannon. Shannon, let's see here. Stress is my major flare-up, and now that I got married a month ago, I'm now living a stress-free life. I've been taking Elmiron and getting installations once a month. It's working for me. So, oh, Shannon. Oh, girl. Hopefully you are fully aware now that Elmiron has been linked to eye disease. And it's not just minor eye disease. It's like could cause blindness eye disease. It's called pigmentary maculopathy. So you're going to want to talk to your doctor about that. You're going to come on over to our website, icnetwork.org. We have an Elmiron Information Center right on the front page of the website. But Elmiron is not being used to the degree that it was being used before, because we now know that we have some patients who are going blind. There are, how many lawsuits do you think have been fired yet? Hello, Heidi. Nice to see you. Nice to see another Heidi. How many lawsuits do you think have been filed so far? Any guesses? 54. 54 lawsuits right now on behalf of IC patients struggling with eye damage. I was working with another patient on Friday who literally is going blind. She's very close to blindness from Elmiron. And we're going to see many, many more. DJ, major flare 2? Holy moly. You guys. Libby says, hi, Jill. I feel fantastic. I hope you're feeling well. I've been consulting with lots of women on Instagram, helping them understand the IC. Girl, thank you. Thank you. She's been able to use the pain subtyping system to save hundreds of women living in constant pain every day and not knowing why or what to do. Candace says, yep, overnight boom. Hello, Crescenda. Shannon says she's only taking 300 milligrams a day. Hun, 300 milligrams a day is still a risk. It's still a risk. In our study of 2,000 patients who have used Elmiron, 54% report eye disease, retinal disease, and several of them report that their eye symptoms began in the first year. Okay. The FDA warning on the Elmiron label says that while it looks like 3 years is kind of the key timeline, but they also acknowledge that patients are reporting changes in their eyes before that. Veronica says she's feeling like crap. Oh, oh my God, you guys. Okay. We have to do a cleanse. We got to get everybody better today. We got to feel everybody better. Make everybody feel a little bit better. And so that's going to be my goal today. You have given me a good challenge. I am ready to go. Now, before we do that, though, I have stuff I got to show you. So hold on a sec. I got a couple of reveals. So I had the honor and privilege yesterday of talking with Dr. Robert Evans, who has been for 6 years and counting the Physician of the Year. So because of COVID and everything else and all the delays at the factories, I could not do our voting and do everything for our IC Awareness Month. Every IC Awareness Month, and guys, September is IC Awareness Month. This is IC Awareness Month. We want you to nominate doctors, nurses, and physical therapists who are treating you well, because they deserve the recognition. And Dr. Robert Evans, Wake Forest Baptist Health, again, the runaway winner. He gets 10 times the number of votes of any other doctor, the doctor in second place. So how cool is this? So we want to give a great big thank you for Dr. Robert Evans for his exemplary care of men, women, and children with IC-PFD and chronic pelvic pain syndrome. This guy is nothing short of astonishing. The great majority of patients, the nominations are amazing. What people are saying about him: he's kind, he's thoughtful, he spends time with you. He's a surgical master. He's an IC researcher like few others, federally funded IC researcher. He's involved with a lot of major research, conducting research. And he also, just out of curiosity, you want to know kind of something interesting about him? He is actually the doctor that does the bladder transplants. And these are done for research purposes. They can actually, at Wake Forest, they have a regenerative, I forget the exact name of the lab, where they have been able to take samples of bladder and actually grow tissue. And so it's very interesting. What you do is you do a deep puncture of the bladder, and you basically get 2 layers. You get the outer muscle of the bladder, and then you get the inner urothelium of the bladder. And so what they do is they grow them separately in the lab, and then they mount them on what they call a scaffold. And they're able to make these cells cover something that will eventually become somebody's new bladder. Usually for kids who have sort of spina bifida, that's usually the target for those. So here you're taking somebody's real cells, so there's no risk of rejection. You're growing a new tissue for their bladder. And now imagine they've got what's basically like a hollow bowl of cells. But the question is, how do you get a blood supply? Right? So they can grow the tissue, but we have to nourish the tissue with blood supply. So how do they do that? And they actually take some of the omentum, they take some of the blood supply in the belly and wrap it around it and implant it. And these kids have done well. And Dr. Robert Evans is a surgery. So that center sold off that right. And I don't remember who they sold it to. What they're doing now is they're creating mini organs. They're creating mini organs, again, with tissue for lab purposes. But he is their primary surgeon. So there you go. Robert Evans, 2019 Physician of the Year. Can I get a congratulations? Hallelujah. We're so grateful for him. He's such a lovely man. I told him yesterday, I wish we could clone you and have you in every state, because we would have tens of thousands of patients who were helped. So now the question then is, okay, I got to be careful because I got to mail this to him tomorrow. Who is the physical therapist of the year? The physical therapist of the year is Rebecca Rauch at the Women's Hospital of Texas. And again, the reviews for her were nothing short of astonishing. Her patients absolutely love the care. She spends a lot of time. She understands IC. She understands the pelvic floor. She's extremely gentle. She will work with you as you're going through kind of that awkward early part of physical therapy where it can be a little bit more painful. So we want to extend our gratitude to Rebecca Rauch at the Women's Hospital of Texas for the 2019 Physical Therapist of the Year. And then the question is, who is the Nurse of the Year? Because honestly, think about it. It's the nurse. See, it always gets so hot whenever I do these. Oh my goodness gracious. That's what happens when you have long hair like I do. Okay. So think about the nurse for a moment. You know, it's really the nurse that's a lifeline of the IC patient. For any urology clinic, there's usually a nurse or a nurse practitioner who is the person you call. They're the person who advocates for you with the doctor. They're the person who might be doing your bladder installations, for better or for worse, because sometimes you want to spend a little bit of time with that doctor, and there are moments when it's a little frustrating to see the nurse, but ultimately in the end, the nurse is your ally. The nurse is your friend. I kind of have this, whenever I work personally with doctors and nurses, I am always going to be as kind as I possibly can. It's going to be very rare that you're ever going to see me angry with a doctor, because I don't want to. I'm trying to remember. When was the last time I was angry? Oh, yeah. Oh. You want to know the last time I was angry at a doctor? It was a radiologist who ignored my urologist's instructions and did a hydrodistension without anesthesia. Yeah. I got her fired. I did. She deserved it. She refused to read my urologist's instructions. I'm laying there. There's a giant bag, 1,000 cc's of fluid that she was going to put in my bladder. I had the instructions from the urologist saying only put 400 in. I'm laying there going, please read. And she didn't. And I was a screaming lunatic at the end of that test. The pain was so bad. And you better damn well believe I was angry, not to her. I went to the president of the hospital. You betcha, my friends. All right, but I didn't need her. I needed my urologist. I try not to alienate the doctors that I know that I need, and I think that that's important. All right. So anyway, not to be sidetracked, the nurse is your ally. Always treat them nicely. Never, ever, ever abuse them in any way. It would be a great loss for you if you walk in and you're angry every single time and they fire you from your clinic, and that happens. So we got to remember that they're our allies. We got to treat them nicely. All right. So anyway, who is the nurse of the year? The nurse of the year is Elizabeth Kusteris at Virtuous Sexual Wellness and Pelvic Health. And again, her nominations were nothing short of just inspiring. Her patients love her. She takes time. She takes care. She goes out of her way to make sure that they can get to work, make sure that there aren't any issues that are interfering with their ability to do what they need to do during the day, like work. And so we want to express our sincere gratitude to Elizabeth Kusteris at Virtuous Sexual Wellness and Public Health for being the 2019 IC Awareness Month Nurse of the Year. Now, if you would like to nominate your doctor, your nurse, your physical therapist, y'all just need to go over to icawareness.org, icawareness.org, and look, I've got it right here. Here you go. Please come on over here and nominate them, because again, the good ones deserve the reward. The good ones deserve the affirmation, the confirmation. They need to know that we appreciate what they're doing. And while you're over there, wouldn't it be great if you told your story? We collect patient stories. This year, our campaign is Your Voice Matters. Your Voice Matters. And so we want to hear your stories. You can submit your story. You can download our posters. You can download our images, our Facebook images. All that sort of stuff is right there. And perhaps most importantly is we have a press release that I would love for you to print out and send to your local paper. The press release is about Elmiron. We want to make sure that we find those patients who have been using it for years, who might be having eye issues. We want to try to protect their eyesight, right? So please come on over to IC Awareness, or we got 10 days left, my friends, 10 days left. Also, we are currently accepting poster. We have a poster contest. We have a meme contest. The winners get $100 gift cards from Amazon. The second place gets $50 gift cards. The third place gets $25 gift cards. And generally, our winner, if we can do it, becomes the official poster for the next year. And so this was our winner last year, and this is our official poster this year. Now, for those of you who are IC Optimist subscribers, who are members to the IC network, guess what I have? Our latest magazine. It's called the Late Summer Magazine. It is a wee bit late, but you know what? It is what it is. So this is our latest IC Optimist magazine. I'm really happy to do a reveal here. And so this is the patient magazine. We've been doing this for 18 years. I can't believe I've been writing this for 18 years with our key writers and guest writers and things like that. So in this issue, I go over all of the details from the latest course on IC that was offered at the American Urology Association conference. This is important. This is important because there are a couple of key themes that have happened this year. Number one, we're now splitting Hunner's lesions off to its own disease. And in Europe, only patients with Hunner's lesions have interstitial cystitis. The rest of us have bladder pain syndrome or chronic pelvic pain syndrome. That is going to be happening in the United States sooner rather than later, most likely. But now there is firm consensus that Hunner's lesions is its own unique disease. Why do we know that? Because when we biopsy lesions, we see a very different process than when we biopsy other patients without lesions. That's theme number one. Theme number two is that glomurulations, those finding of pinpoint hemorrhages on the bladder, are now considered meaningless. And so let me get a picture here. Hold on. All right. All righty then. So for those of you who have had bladders that have had little red spots on them like this, we call these petechial hemorrhages, glomurulations. These are now considered fairly meaningless. We actually believe that these are the result of the test. How do we know that? Because when you do a hydrodistension of normal women who have no bladder symptoms, bam, same thing happens. So this is no longer going to be associated with the finding of interstitial cystitis. Okay, hold on. Let's see here. The third interesting thing was the fact that, let's see. So this was a class taught by an international team of doctors. We had Dr. Phil Hanno from the United States, Dr. Sandor Lovaz from, I think, Poland, and who was the third doctor? And Jay Quentin Clements, also from the United States, right? So here's something. Now, y'all got to understand here that we really think of IC as injury more than illness. And with the exception of Hunner's lesions or maybe some sort of chronic fungal or viral or bacterial infection, really the concept of injury is something you've got to understand. And so Dr. Lovaz, fascinating, he actually revealed what he thinks triggers that bladder injury and makes that bladder injury persist, right? So he says, number one, a bladder insult first occurs perhaps from a UTI or chemotherapy or holding your urine too long. Something happens, just irritates the bladder. The bladder wall becomes damaged. And okay, so that's number two. The bladder wall is now physically damaged. Number three, through that damaged area, urine leaks into the bladder wall, including the potent ion potassium. And potassium is known to be particularly irritating, where it triggers a variety of reactions in the bladder wall. Number four, because of that, now we got urine where it's not supposed to be. Urine is now deep in the bladder wall. Mast cells become activated and release histamine, and then the nerves all get irritated. And that's where the vicious cycle happens, because now we've got a progressive bladder injury which is also triggering the pelvic floor muscles to tighten and causing an inflammatory reaction in the sensory nerves and the spinal cord, right? Injury, not illness, injury, trauma. And so when some of you say, what's the cure? What's the cure? That's not the right word, because you don't cure injuries, you heal injuries. And our goal here now is to try to figure out what was physically injured. What was injured? Was it your bladder wall? Was it your pelvic floor? Or is there something else that is involved? And then our job as patients is to create an environment that will support healing, that will support tissue repair. Because the one thing you can count on is that healing is always happening. Always. That never stops. Healing will not stop until you and I are dead. And so the bladder absolutely is trying to repair itself. The muscles absolutely are trying to repair themselves. But the challenge is that we often get in the way. How do we get in the way of bladder healing? Well, by drinking coffee every day or soda every day. If you had a wound on your hand and you poured acid on it every day, what's going to happen to the wound? It's going to get worse. And it's certainly not going to heal. It's going to get physically worse. I attended a lecture by Dr. Anthony Schaefer, who is one of the top urologists in the nation. He might even be retired now, about 10 years ago, 15 years ago. And he was talking about how the bladder wall repairs itself. And what he said is that the bladder is the slowest healing organ in the body. Nothing happens overnight. It is physiologically impossible for the bladder to repair itself in a day or a week, because it takes a minimum of 2 weeks for a urothelial cell to be replaced. And so imagine an extra large pizza, and imagine underneath that pizza a little tiny green pea. So that pizza is your giant umbrella cell. These are the biggest cells in the human body that help protect the bladder wall. And underneath that, you've got a little tiny stem cell. So the pizza, the umbrella cell, is now destroyed. This little pea, this little stem cell, is going to have to grow. It's got to become very big, and then it's got to change shape to fill in that spot. And unfortunately, while it's doing it, it is exquisitely sensitive to acid. And so basically what he said is, while that stem cell is growing, it's going to be killed easily with something acidic like coffee or like soda. And we've all known this in the IC world. The people who suffer the most by far are the people who drink 1 cup of coffee a day. If you've got IC subtype 2 bladder wall driven, if you're drinking coffee every day, you're literally destroying the next generation of cells that would normally be replacing your bladder. Are healing your bladder. And so when you've got a bladder injury, like I had when I suffered my chemical burn, or if you're a chemotherapy patient, your number one job is to create an environment that will support healing. And that means you can't pour acid on the wound every day. Right? Right. Let's see what else is in here in this magazine. So again, we are talking about the newly released IC Optimist. My baby. In my editorial, you guys listen, I'm real honest here. I mean, our campaign for IC Awareness Month is Your Voice Matters, but in this era, feels like it's not the right time to be talking about IC when we've got so many other things going on too, although I know it is. But in context, there's so many things happening in our daily lives. I do want you to know that the week after the election is a very, very important Supreme Court case, Texas versus whoever. I have it right here. California versus Texas, a lawsuit brought by the Trump administration to dismantle the Affordable Care Act. If this is successful, it would not only end health coverage for 23 million, it would end protections for millions of people with pre-existing conditions like IC. And so if you have a pre-existing condition and you value your health insurance, you have to understand that that's happening the week after the election. And now that Ruth Bader Ginsburg is gone, we have a 4-4 tie, and we don't know what's going to happen. And so regardless of what anybody says that they're going to cover pre-existing, no, then why is there a case in front of the Supreme Court? Understand too that IC patients cannot stand in line to vote. We need restroom access. So expecting any IC patient to stand an hour, 2 hours, 3 hours, 4 hours, 10 hours to vote, not going to happen. And so make sure that you do mail-in voting. Make sure that you sign up for that. It's important. Your vote matters. And then last but not least, it is very important that you understand that there has been some discussion about removing the payroll tax that supports Social Security. And so the Social Security actuary issued a statement that if that payroll tax is removed, the Social Security disability benefits will end next year, that the trust fund will be emptied next year, and that your retirement benefits would end in 2023 if the president passes what he is saying he will pass, which is a reduction in this specific payroll tax. This is all on the record. I'm not telling you who to vote for. I'm just educating you. All right. Another thing that happened at the event at AUA was a brilliant lecture by Dr. Curtis Nickel, the top IC researcher in Canada, who talked about the impact of the urinary biome, the good bacteria. And fascinating. While it might only weigh 3 to 4 pounds, your body has more microbial cells than human cells. That we rely on bacteria to live, to help digest food, to nourish the cells in our body. We are only alive because we have the assistance of bacteria. And of course, when you take an antibiotic, it's like taking a flamethrower to rainlands or wetlands. It's terrible. And so what we're learning now is what role some of these bacteria play, and how is the biome changed in the IC patient or the IBS patient. We know, for example, that many patients are flaring because they have an overgrowth of candida in their urine. That is research from the National Institutes of Health. Not only have we found fungus in the urine of patients who are flaring, but we have also found 13 species of fungi. And that the more fungi you have, the worse your pain. So if you flare when you eat sugar or carbs, you could have a fungal infection. What is the risk factor for having fungal infections? Taking antibiotics. You know, a lot of you self-medicate. You just take antibiotics when you have a flare. Stop it. Don't do that. You only take an antibiotic if you have a confirmed infection, because we're now understanding the damage that 60 years of antibiotics have done on the urinary tract. So here's what we knew about that. The biome keeps us alive. Okay, well, duh. The first study, released in 2019, found 330 bacteria associated with infection in the urinary tract. The next study found 4,000 species of bacteria living in the urinary tract, and then there was another one after that. We also know that where urine is sampled is important, because you have different bacteria in your urethra, different bacteria on your vulva, different bacteria in your bladder, low in the bladder, high in the bladder. So where we take the urine is important. And interestingly, he predicts that next generation urine testing is going to be replacing a typical urine culture sooner rather than later. He encourages every doctor to start using next generation DNA urine testing. And he acknowledges it's hard to understand the data, but that he says, I predict it will not be long before we abandon the Petri dish for the PCR test, the next generation test. We go over the new warning label for Elmiron. Let's see, what else? I have a transition plan here for people who are trying to get off of Elmiron. What are your options? Because the options are fairly limited. You know, and Sarah says, what supplements does everyone take to reduce a flare? So far, I've only found the aloe capsules. Hun, we got Bladder Builder. Look at, here they are right here. Here's a picture of them. Bladder rest, bladder builder, allopath. Allopath is aloe with PEA in it. PEA is a pain reducer. So we're extremely happy with the new aloe. And then for people with nerve sensitization like me, we want to do something that's PEA based, Peora. And this is a supplement that I take because that is my subtype now, as I struggle more with nerve pain. And so PEA, palmitoethanolamide, we have research that proves that PEA can dramatically reduce the pain of IC. In a research study from Europe last year, at month 3, 87% of patients using PEA had a significant response in their pain, reduction in their pain. By month 6, 25% of those patients were pain-free, and the rest had significantly improved. And these were patients who had not responded to any of the therapies, right? And so intractable patients. So Peora, PEA, is the American version of that formula that was used in Europe. And this would be something that might be interesting to try. Might be very interesting to try. And interestingly, it's actually the cheapest supplement there is. It's $24.99. So it's a pretty good experiment. Stacy Shannon did a wonderful article on fibro, one of the related conditions to IC. We go over birth control pills, how for some patients, birth control can trigger the onset of IC bladder wall-driven symptoms by changing the character of the bladder wall in some of you. We go over the latest research, including a new study on riding a bicycle and what that does. And hot and friendly cold drinks with a good self-help tip. IC Awareness Month, Clinician of the Year Awards, and there you have it. There you have it. So again, if you would like to get the IC Optimist, you just need to become a member of the IC Network. However, I always have freebies. I have 5 copies that I can send out tomorrow. 5 copies that I can send to anybody tomorrow. Actually, let's make it 6. I think I have 6. I count 1, 2, 3, 4, 5. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Oh, I got 10 freebies, guys. 10 freebies. So anybody who wants one of these, pop me an email, icnetwork@mac.com, icnetwork@mac for Macintosh computer, MAC. icnetwork@mac.com. Put your mailing address in there, and I will mail 8 or 9 or 10 of you the latest IC Optimist so you can read it, okay? That is my gift to you. All righty then. Let me have a drink of water. I've been drinking water like mad because it's hot again. So give me a quick second. Guys, quick bio break. Time to use the restroom. I'll be right back. Then, alrighty. Let us, you know what? Like I am hot. I'm hot. All right, Ruth, I see your email. Make sure you put your address in there. Anybody who wants our IC Optimist magazine, all you need to do is put your address in that email, and I will send it to you. If you are international outside of the United States, pop me your email address and I will email you a copy of it. Okay? Hold on. What am I going to do with this hair, guys? You see how, for those of you who've been following me, man, I had it cut a year ago up to my shoulders. That's how fast my hair grows. It's ridiculous. It's like I have a giant bear pelt on the top of my head. Whew. Okay. Whew, that's better. That's better. All right. Thank you, Donna. Thank you, Donna. Donna, I'm telling you, girl, whenever I need a boost, there you are. Yeah, anybody who wants an email wants a copy, send it to me. And I've got a few here. I got like 10 here. I'm more than happy to send them out. All right. So let's take some questions here. Let's see how you're doing. Janine has no volume. Y'all can hear me, right? Stress and traveling in a car for 12 hours has my IC and fibro flailing. Yes, girl, it would. That's pretty brutal. That's pretty brutal. Long car rides are tough, especially if you got pelvic floor dysfunction. Hopefully, let's see if I have them. You know, one of the things that you should have in your car are travel johns. For anybody out there, travel johns. These are amazing. So if you're stuck in a car and you got somebody who won't pull over, or you're stuck out in the middle of the desert and there's no bathroom. So it comes wrapped up. Hi, Holly. I got your email. That's great. Thank you. Okay. So this is super, super small, right? And when you unwrap it, you can see it fits right where you need it to fit. And it has powder in it. You can see the powder. So as soon as any liquid gets in here, the powder immediately turns solid, so it's not going to leak. So you can just pee into this and throw it in the next trash can, and you'll be fine. This is what pilots use when they're flying across the country in small planes, a travel john. Guys, it should be in every car, and you can find this in our store. Janine says, are there any medications you need to take? Janine, you need to give me more. So you guys remember on Facebook, it scrolls by so quickly, I miss half of what you're saying. And so please ask it again. Becky says, I have thrush and yeast infections recurring from antibiotics, and my doctor knows I have IC, going to bring this up at the next appointment. Becky, I got a couple articles on our website about it. I just go on over to the IC network and you can search for Candida. And you can pull those articles and print those articles because they give the research studies. Oh, God, look at that, you guys. You're scrolling by so quickly. Janine says, what's it called? Oh, Peora, palmitoethanolamide, Peaora. Here is it's in my bedroom, actually. Let me go get it. Hold on. I'm not here pushing supplements here. That's not my job to push supplements. The American Urology Association encourages you to use supplements in step 1 of their IC treatment guidelines, because supplements contain fewer risks of adverse events than traditional medications. And now that Elmiron has been linked to retinal damage, and there's no other traditional therapy, FDA-approved therapy, that has a bladder coating effect, patients have moved to chondroitin-based supplements. Whoops. Oh, wait. So here's Peora. It's in a blue bottle. And I can go over those if people have any questions. All right, but let's see here. Shannon says, I take 300 milligrams a day, but it really helps me. I need to find an alternative. So Shannon, the alternatives are going to be either bladder installations. You can have a chondroitin-based bladder installation, or you can have an Elmiron bladder installation if you're willing to be catheterized. And they can teach you how to do that at home if you'd like to do that. Or your other options are really going to be the chondroitin-based supplements, because it's chondroitin that also acts to coat the bladder wall. Beverly, it's not icnetwork.com. It's icnetwork.org. icnetwork.org. So we were not able, somebody stole that domain name from us about 25 years ago, and I have yet to be able to get it back. We've even offered thousands of dollars for it. Somebody in Korea owns it now. So the chondroitin-based supplements are going to be... Let's see, Bladder Builder. And Bladder Builder right now is the top supplement because in addition to the chondroitin it has for the bladder wall, it's got PEA for pain relief. And in fact, Dr. Evans told me yesterday that he's getting good results with Bladder Builder in his clinic. So Bladder Builder, number one. For people who are a bit more on the sensitive side, and you cannot take probiotics because they give you flares, acidophilus might give you a flare, and Bladder Builder has acidophilus in it. So if you're acidophilus sensitive, you want to go with the cleaner formula, Bladder Rest. Not as many ingredients in there that you can react to. Or the old beloved favorite, Cysto Protect. But Cysto Protect does not have a PEA in it, but it's still, quite a few of you still love Cysto Protect or Cysto Renew. And Shannon, just so you understand, people have been getting off of Elmiron for the last 10 years now because it's so expensive. So this is nothing new. We have been doing this transition for years now. It's just the new thing is the eye disease, but many patients have had to get off of Elmiron because they couldn't afford it. Libby says, what's the address again? icnetwork@mac.com. icnetwork@mac.com. All right. Oh, this is cool. I kind of got this set up right. Let's see here. Donna says, travel gens are a lifesaver. They are great. Thank you, Holly. Nicole says, can an IUD affect IC such as Mirena? Possibly. That's certainly been brought up several times by patients with Mirena. You know, everybody's different, but what we do know is that the bladder is remarkably responsive to changes in hormones. And so it is possible. Denise says, I have a tilted uterus. I couldn't tolerate IUD. Yeah, there you go. Denise. Hey, man, you know what, Denise? The revenge of the redheads is for everybody who teased us that we have red hair. The cool thing about being a redhead is you don't go gray. You just kind of slowly become a strawberry blonde and then blonde. Maria says, have you heard of an amniotic fluid injection to the bladder to reduce inflammation? The answer is no. I do not believe I have ever seen a research study that has talked about that. You guys, you have to email me. Don't respond in the chat. Email me if you want the magazine. Claire says, is this where I send the email to get the IC Optimist? No, it's icnetwork@mac.com. Jan says, Jan, welcome to the IC Network. She says, I am newly diagnosed and freaked out. Hold on. I think your spell corrector. Urologist casually gave me the IC diet 2 weeks in. It's not helping much. You started to have symptoms in the early summer. All right, guys, for Jan, let's do this. We got to do this, guys. So hold on a sec. Let me get my notes here. You would think, I mean, if I weren't simulcasting on two platforms, I'd be able to share my screen, but I can't do that. So hold on a sec. Hold on. Where is it? Where is it? Where is it? Here it is. Okay. All right, my friends. All right, my friends. Let's talk turkey here. Let's talk turkey. Even though you have been diagnosed with interstitial cystitis, the problem is your IC may be different than my IC. Why? Because there is tremendous diversity in this patient population. For some people, IC begins in childhood. For others, IC begins after menopause. Are they the same? Hell no, they're not the same. For some of you, IC begins after chemotherapy. For others, IC begins after, unfortunately, maybe being raped. Are they the same? No, they're not. And when you look at the bladder, that's where you really see differences, because some of you have completely normal bladders. Others have red spots on your bladder, which we now know is because of the test. And still others have big bloody wounds called Hunner's lesions. So, and we have long known that bladder therapies didn't work for everybody. In fact, bladder therapies work for comparatively few people. Why? Why? Because for some of you, it's not the bladder. We no longer consider IC an incurable bladder disease, my friends. We consider IC a chronic pelvic pain syndrome. Why? Because we now know that there are structures outside of the bladder that can give you bladder symptoms. Remember, the bladder only knows one language: frequency, urgency, pressure, pain. So a bullet wound would feel like an infection. A stab wound would feel like an infection. An injury feels like infection. Cancer feels like infection. Because the only language that the bladder knows to tell you that there's a problem is by giving you the symptoms of frequency, urgency, pressure, pain. So the odds are 95% of you, when you first got your symptoms, you thought it was infection, and you went to the doctor and said, "Hey doc, I think I have an infection." The doctor goes, "Okay, let's test your urine." Your urine comes back negative. The doctor goes, "Well, you don't really have an infection. Maybe it's all in your head. Or maybe you drink too much coffee," or whatever, right? And you're going, "What the hell is wrong with me? It feels like infection, for God's sake. Why is my urine negative for infection? What? Why? And this is really the challenge of IC, is that this is a pelvic pain syndrome. Now consider the pelvis. I'm going to bring out my number one favorite demo right here. Your pelvis is the core of the human body, right? It has, hold on, the largest bones in the human body. Hello, your hip bones. The way the human body is built is the bigger the bone, the more weight it is meant to hold. So your biggest bones are in your pelvis, right? So we know that your pelvis is structural. We know that your pelvis helps keep your body upright. We also know that your pelvis absorbs the stress of when you walk. So if you walk or stumble, or let's just say you walk with a bad hip, all of that muscle stress is going to be reflected directly up into the pelvis. The other thing that happens in the pelvis is that we've got blood vessels that go from the heart, and then they go through the base of the pelvis, and they go down both legs. We know that you've got nerves that come off of the sacrum. See, here's your sacrum. Let's go to the back side, right? So this is your sacrum. Here's your tailbone right here. So we know that there are nerves that emerge through these holes, merge together to form the pudendal nerve, and then go through a couple of structures, and then it splits apart. And you have nerves that also go down your legs. So there's a lot of stuff happening in the pelvis, right? There's a lot of stuff happening. But then we've got organs. So now we got to fill this sucker up with organs. So hold on. I got to put the vulva on. So let me, actually not the vulva, the levator ani muscles. Other thing to understand about the pelvis is that there are lots and lots of, there are three very distinct layers of muscle. So here's the lowest layer. These are your levator ani. They go from front to back. So they basically go from your tailbone, by your rectum, across your vagina, across your urethra, and up towards the front, your pubis area. Okay, so here we go. So here's your pelvis. So now we got to put, for a woman at least, let's put the uterus in. All right. Come on, uterus, get in there. If you guys knew how this is for anybody. Okay, hold on. The vulva fell off. No, the levator fell off. Hold on. That's just my running joke every meeting now. Is the levator fell off. Okay. All right. So, oh, come on, get in there. Okay. So now we've got the vagina and we got the ovaries in there, right? And we got to put the bladder in. Okay, now we got the bladder in there. Then, of course, we got the bowel. We got to stick the bowel in there. I'm not even going to try to attach that. That's really hard to attach. Right? Okay, so look, the pelvic cavity. There's a hell of a lot of stuff happening in the pelvic cavity, right? And this is where Western medicine fails. Because doctors stay in their box. A urologist is happy in the urinary tract. That's what they've studied. A gynecologist is happy in the reproductive system. That's what they've studied. A gastroenterologist is happy with the bowel. That's what they've studied. What they haven't studied is how they relate to each other, how they influence each other. Specifically, also, how the muscles influence them all. Because, whoops, get back here. Okay, uterus, you're done. Get up. All right. I love this. I mean, honestly, I love this. Okay, so look at the levator muscles. So here are the levator muscles. Here's your rectum for women. Here's your vagina. And here is your urethra. I don't know if you can see the urethra is right there, right? And look, here's your perineum right there. That's your perineum. The levator ani muscles are the only muscle group in the human body that absolutely influence major bodily functions because they're basically three holes, right? The levator ani have to have a place for bowel movements to come out. It has to have a place for babies to come out, and it has to have a place for urine to come out. So if these muscles are tight, what do you think happens? It's hard to let stuff out. It's hard to pee. It's hard to have a bowel movement. And it's hard to let stuff in for a woman like a penis. That's why intimacy is painful because in many cases, muscles are tight. So we learned in 2008, when the National Institutes of Health released their first pelvic floor physical therapy study, what we learned in that study in 2008 is that pelvic floor physical therapy is remarkably successful at reducing IC symptoms, more successful than most treatments. And it was at that moment in 2008, the IC world was put on its head because guess what? If this were a bladder disease, muscle therapy shouldn't work. And it was at that point we all had to take a step back and go, uh-oh, wait, what? And if you go back and you look at the literature, you will see for 100 years, doctors have been describing muscles so tight they resemble tight piano strings. But the problem is that the urologist couldn't interpret that. They didn't understand what was happening. They saw the tight muscles, but they continued to do bladder therapies. And guess what? Patients were not getting better. So for about the last 10 years or so, there's been a bit of an informal contest among IC researchers around the world. What they're trying to do now is to define the variants of IC. We're no longer making all-in-one statements that everybody has bladder disease or everybody has a pelvic floor injury or everybody has infection. We're not doing that anymore. We're now diagnosing patients and trying to understand your unique variant of IC. Because wouldn't it be a shame if you spent 20 years on Elmiron and went blind on Elmiron only to discover after the fact that your bladder was healthy and it was always your muscles or maybe a fibroid tumor pushing on your bladder or maybe polycystic ovarian syndrome or maybe a Tarlov cyst. There are all sorts of things. So we don't want to do that anymore. We don't want to make those mistakes anymore. That is a mistake. That is a mistake. So in Europe, there are at least 12 variations of IC who often have different therapies. They require biopsies. In the United States, we're not going to do biopsies. Insurance won't pay for it, number one. And number two, absolutely, we don't want to traumatize that patients more. The purpose of the American Urology Association guidelines for IC is to not wound, not injure, not work things up. Tammy says they put Elmiron in your bladder. Yeah, it can be a bladder installation. They put Elmiron in the bladder for many years now. You know, when you swallow Elmiron, if you swallowed a Band-Aid, would you expect it to come out the other end a Band-Aid? And the answer is no, of course not. You have digestion. And the problem with Elmiron, with research produced by the company itself, is that 93% of the Elmiron you swallow is rendered inactive by digestion. Only a small percentage, at most 7%, might arrive in your bladder to do anything beneficial. And I was talking to a doctor earlier this year who said he actually thinks it's like 3%. And that's why when you take Elmiron, you have to take a lot of it over a long period of time because most of it's destroyed by digestion. But if you put the medication directly in the bladder, 100% of the medication arrives in the bladder where it can work as a bladder coating and is not distributed to any great extent systemically. At least we're not aware of that as yet. Generally, topical medications stay in the area that they're applied. Cindy said, will amino acids affect IC? And the answer is probably not. I wouldn't expect that. Okay. So, whoops, what is that? Okay. All right. So in Europe, there are 12 variants of IC. In Canada, they use a system called input, U-point, or input, where they ask doctors in Canada to look at a patient's bladder, to look at their symptoms, to look at their muscles, to look for the presence of infection, and to see if that patient has any other neurologically driven pain conditions like fibromyalgia. Then based upon that, they create a customized treatment plan in Canada. Now, for anybody watching from Canada, I don't need to tell you, you already know that Canada has for many, many years been far behind the rest of the world. But with this new, their new IC guidelines and diagnostic system, things are improving as long as your doctor knows about it. So if you're in Canada, please Google Canada IC guidelines so that you can print them out and bring them to your doctor. So what the hell do we do in the United States? Well, we don't have a nationally agreed upon system. So I use a system that was created by Dr. Christopher Payne, who ran the IC research program at Stanford University, federally funded IC researcher. He was a chairman of a couple of the IC National Institutes of Health IC meetings, all around very, very nice guy. So he brought in about 5 years ago his own subtyping system, and that is what I use extensively, and it has been absolutely fabulous for us. It's a great clinical tool. It's not perfect, but it's a good start to try to help you understand what could be triggering your IC symptoms. Lisa, yes, that is right too. IC-network.com works or ICnetwork.org works. So when Dr. Payne introduced his system, Chris Payne, he's now at Vista Urology, which is the pelvic pain center of the West Coast, pretty much. He did it in a very provocative way because he said, we should be treating IC patients like cancer patients. And of course, in my brain, I'm going, oh my God, don't say cancer and scare people. There's no connection between IC and cancer, my friends. The only connection that we see is sometimes it's missed if you're a smoker. The number one cause of bladder cancer is smoking. Please, 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 please don't put carcinogens in your bladder. You've got to let the smoking go, especially if you've got a wounded bladder. That's allowing the carcinogens now to penetrate deeply into your bladder wall, which can cause cancer. Okay. But anyway, to get back to my point, there's no relationship between IC and cancer other than occasionally it's missed. But he makes a good point. He goes, listen, when somebody's diagnosed with cancer, they don't just say you have cancer and send you out the door. They tell you you've got cancer of the left breast and it's estrogen dependent type 1, 2, 3. Or in my case, they told me I had complex endometrial hyperplasia with atypia and a vague architectural complex. What did that mean? Early uterine cancer, which is 3 years ago. And we knew, based upon that diagnosis, that the correct therapy for me was an immediate hysterectomy, which we did. Dr. Payne argues that a diagnosis of IC is fairly meaningless because you don't know, neither you nor your doctor really know what to do next. There's no intuitive therapy for you if you're told that you have IC. So how can we give you an intuitive treatment plan? We give it to you with specificity. We need to give you a more specific diagnosis to try to help you understand what your treatment options are. All right, so here we go. In his system, we got 5 core subtypes, and then in some of these groups, we have mini subtypes. All right, IC subtype 1, Hunner's lesions. Everybody in the world agrees that this is a distinct group of patients. Why? Because when we biopsy these lesions, there is something different happening. There is massive inflammation, and there is an absolute breakdown of the bladder wall in Hunner's lesion patients. That bladder, the top layer of the bladder is often severely damaged. Lori says, my urethra is in a flare. It hurts to sit too much. Lori, I've got a blog on our website, The 7 Causes of Urethral Pain. It's going over there, icnetwork.com, and just put in urethral pain, and that'll work through that list, and then you can come back. Hi, David. Okay, everybody in the world agrees Hunner's lesions is its own unique group. Okay, so if you've got Hunner's lesions, you've got to do Hunner's lesion specific therapy, and that's going to be number 1, cauterizing them, lasering them, injecting them with a steroid, hyperbaric oxygen therapy, Lyris, which is currently not available. Lyris is the only treatment that has actually healed Hunner's lesions in 2 weeks, or cyclosporin. Cyclosporin has been found to be quite helpful in the treatment of Hunner's lesions. All right. So that's, maybe 5 to 15% of you might have Hunner's lesions. You might be surprised to learn that Hunner's lesions have now been connected with viral infections. We now have a couple of studies from Europe and now 1 study in the United States that is consistently finding viral infection in some of you. Okay. IC subtype 2. IC subtype 2. Bladder wall driven. Because, the bladder can be injured like any other part of the body. There's no doubt about that. The bladder can be injured. So how is the bladder normally injured? Number 1, with chemicals. Chemotherapy, ketamine. There's some antibiotics that are incredibly harsh to the bladder, like Augmentin. Or, in my case, it was swimming pool chemicals. Or, listen, if you drink diet soda, got to understand that artificial sugar, NutraSweet, is metabolized into formic acid and can be devastating to a bladder wall. Absolutely devastating to a bladder wall. So we're going to look first at chemical injury. And our therapeutic priority for the chemical injury patient is to stop whatever it is that's irritating the bladder and then calm and soothe the bladder and give it some time to heal, because healing can happen. Our second variant for this is estrogen atrophy. If your symptoms started after hysterectomy, if your symptoms started after the age of 50, or maybe before then when you're perimenopausal, you have to understand that the bladder uses estrogen to produce mucus. Your bladder is like your mouth. It's a mucous membrane organ. There's a thick coating of mucus in there that that repels urine. It acts as a barrier so that urine cannot touch the more fragile cells beneath. But unfortunately, that nice thick mucosal barrier that Dr. Parsons calls the mighty mucus is estrogen dependent. So when you're young and you have lots of estrogen, you've got lots of mucus. When you're older, you have much less estrogen and much less mucus. Thus, your bladder is going to be more vulnerable. Hey, DJ, I want you to bring that back when I'm finished with this section, okay? Because I'd like to talk to you about that. Okay, so it's not a disease process. Genitourinary syndrome happens because your bladder wall is more vulnerable because of the loss of estrogen. And this is when there are women who suddenly, in your 30s and 40s, you had your sweet tea every day or your soda every day, your coffee every day. And then finally in your 50s, all of a sudden they hurt. Okay, it's not a disease process. It just means your skin can't defend itself. So our therapeutic priority for these patients is, number one, perhaps to give them some estrogen so that their body can start producing mucus again. So using a topical estrogen is very common. And then using a bladder coating that might give the bladder wall a little bit of extra protection makes sense. So that's where Elmiron might have helped. And that's where a bladder wall installation or a chondroitin-based supplement like Bladder Builder might help with estrogen atrophy. The third variant for subtype 2 bladder wall driven is chronic infection. Because yes, some of you might have chronic infection. No doubt about it. Not all of you, but some of you could. And this is where next generation urine testing can be remarkably helpful. Because again, remember that it was our own National Institutes of Health who discovered fungus in the urine of IC patients. Here, Lisa says, I'm very confused if Hunter's lesions are different than crack. No, cracks can be lesions. That's another way of describing it. Okay, so remember, getting back to chronic fungal infection, it was our own National Institutes of Health who made that discovery. The problem is a typical urine test doesn't test for fungus. So here, you're sure you have an infection. You've got frequency, urgency, pressure, pain. Doctor, it has to be an infection. Help me. And they do a culture and it's negative. Yeah, it's negative for bacteria. But what about fungus? What about fungus? That's a huge missing piece. That is a huge missing piece here. And so now, whoops, the bell almost fell on the floor. So now, what the American Urology Association, through Curtis Nickel, through a lecture he just did to the AUA this summer, is telling people that next generation DNA urine testing is the future because it will tell you good bacteria, it will tell you bad bacteria, but most importantly, it will tell you fungus. Now, I will tell you, I had a chronic fungal infection in my urine for 2 years. It happened after I did Augmentin for 6 months. And it was a drug-resistant Candida glabrata that was identified by my gynecologist. That fungal infection was the worst pain I'd ever had. Far worse than the bladder injury. Having a Candida infection in your bladder can be agony. Absolute agony. All right. All right. So those, and then another variant of bladder wall driven could be birth control, because we now know that there are some patients who, we have a brand new case study, 2 weeks, an 18-year-old girl, 2 weeks after starting birth control pills, came down with all the symptoms of IC, frequency, urgency, pressure, pain. And over a period of a year, it got worse and worse and worse and worse. And every doctor she saw gave her completely different diagnoses. One said IC, one said yeast. I forget what the other said, but she was just suffering. And they were looking at her like she was crazy. And I'm sure at some point in time, somebody said it was all in her head. And then finally, she went from doctor to doctor to doctor. That was a sign of a really good mom. who just refused to accept no. Finally, a doctor said, "Hey, did you start birth control?" And she went, "Yeah." He goes, "Let's stop it. Stop the birth control." And what do you think happened? 2 months later, she was symptom free, and her symptoms improved immediately. It was just a slow, gradual process. And that's a good lesson, that it took 2 months for her to go back to being normal, because that's how long, hormone changes are very slow. But the point is that they found what triggered hers, which was a change in her hormones driven by birth control pills. Okay, let's go to the third subtype. The third subtype is the biggest subtype: pelvic floor driven. Pelvic floor driven. Here, hold on. I got to be organized here. So these are the patients whose symptoms began not after a bladder injury, but a muscle injury, a fall, a car accident, a history of athletics. Were you a horseback rider, got thrown off a horse? Were you an ice skater, kept falling? Were you a paratrooper, where you had a couple of hard falls from the parachute when landing on the ground? Were you a football player? Were you a wrestler? You ever remember breaking your tailbone? There are 2 reflexes in the pelvis. So when we get back to this rich, robust pelvic floor cavity that you have to understand. The first one is called, now you guys, for my giveaway, I'm giving you a clue right now. Write one of these down. The viscerosomatic reflex, viscerosomatic. The viscerosomatic reflex. Viscero stands for viscera, an organ. Somatic stands for muscle. So in the viscerosomatic reflex, it's basically, can an organ change muscle behavior? And the answer is absolutely. Because if you're in pain, your muscles will get tight to protect you, right? That's called the guarding reflex. So if you have, there are so many examples I could give. What did I do with my, oh, here we go. Here it is. So let's just say, let's give you a good example. Let's say, that you've got a bladder infection, right? So you've got a bladder infection, and your bladder is screaming in pain. The muscles in the area are going to respond to that pain by getting tight. And so what that means then is the levator ani muscles, the muscles down at the bottom, are going, instead of being pliant like this, they start to do this. They start to get very tight. And what happens? It's hard to pee. Sex can be painful, right? Or if you've ever had Montezuma's revenge, like really bad food poisoning, and at this point in time, how many of us haven't? Where you got diarrhea like for hours and hours and hours, and you might notice that it's hard to pee because your muscles are so tight and spasming. So when this muscle gets tight, it's hard to pee and it's hard to have a bowel movement. It's just hard. So we know through the viscerosomatic reflex that organs can change muscle behavior. And our therapeutic priority for these people is, if you've got a chemical injury or whatever, if we calm and soothe the bladder, we know that the muscles should release. But there's another reflex that's more important, that's more interesting. It's called a somatovisceral reflex. And that is, can a muscle change organ behavior? Interesting question. And the answer is yes. Yes. Because if these muscles are tight, well, you can't poop easily, you can't pee easily. So we know that's immediately going to change those functions. But we also know that injuries, especially injuries that result in trigger points where you've got muscle knots in your pelvis for months or years, that's also going to dramatically restrict blood flow to the bladder and other organs. And it's also going to start inflaming and irritating nerves. And so we know that if you fell on your hip or on your butt, and that injury was never addressed, and that muscle just gets tighter and tighter and tighter and tighter and tighter and tighter. The long-term consequences of that mean that the nerves supporting your bladder are also going to become inflamed, and your bladder wall can start to break down. There's a long, complex explanation for the biological process that happens, but I will just tell you that it is absolutely impossible for your organs to be healthy if your muscles are tight, because tight muscles squeeze nerves and damage blood vessels, and that's a problem. So getting back to the subtype, pelvic floor driven. So what's the difference? How do we know you've got pelvic floor dysfunction? If you have bladder wall pain, your pain gets worse as your bladder fills with urine, and it is relieved by urination. So if you have wounds on your bladder, oh wait, that's not the right picture. Here we go. This is the picture. All right. So here, this is absolutely a wounded bladder, right? So you can see this. As your bladder gets fuller and fuller and fuller and fuller and fuller with urine, urine is going to get into these wounds, and it's going to hurt like hell. As soon as you pee, guess what? Urine is no longer in the wounds. You feel. So bladder wall pain happens as your bladder is filling with urine, and then you feel better after you pee. And bladder wall pain is characterized by being very sharp. It feels like razor blades, ground glass. For me, it felt like there was like sharp fingernails that were going up and down my bladder wall. It's very eerie that you can actually feel your bladder wall when you're really never supposed to feel it. But that's what it felt like for me. So with bladder wall pain, your pain is the worst as your bladder gets full. Pelvic floor pain, your pain is often the worst after you're done peeing. After you're done peeing. And pelvic floor pain is not as intense. It's duller. It's achier. It has a burning quality to it because a muscle that's working hard is a muscle that builds up lactic acid. So there's definitely a burning sensation there. But most importantly, the way we know you've got pelvic floor dysfunction is if you feel a falling sensation, a pulling sensation, a pushing sensation, or you cannot start your urine stream right away. That you hesitate 5, 10, 15, 20, 30 seconds, a minute, 2 minutes, 3 minutes, 5 minutes, 10 minutes before you can relax these muscles to empty your bladder. Now, can you have both? Absolutely. You absolutely can have both. I call that the chicken versus the egg dilemma. Which comes first, the chicken or the egg? For us, it's which comes first, the bladder or the pelvic floor. The reality is that they're both involved because they're so incredibly interconnected, but one is normally driving the other. And so for some of you, yeah, man, some of you had terrible diet soda habit. All you drank was diet soda. You had no concept of what the damage that was doing to your bladder wall over time, and your bladder wall started to break down. And then because your bladder wall was in pain, your muscles got tight. That is a bladder wall patient. Our therapeutic priority is to calm and soothe the bladder. But if your symptoms began after a muscle injury, like a fall or a car accident, man, you have no clue you have a muscle injury. You have no freaking clue at all. None. Your first symptoms, frequency, urgency. They tell you got a urinary tract infection. They give you antibiotics. Your test comes back negative. The antibiotics don't work. You go back to the doctor. Doctor goes, maybe you got overactive bladder, or maybe you've got prostatitis. They give you those meds. They don't work. You go back to the doctor. The doctor goes, oh, I hate to break it to you, but I think you've got this really awful condition called interstitial cystitis. Here's the diet. Here's some Elmiron. Send you on the way. You try that. Yeah, your symptoms might be a little bit improved with the diet, but the Elmiron doesn't work. And you take the Elmiron for 5, 10, 15, 20 years, but are you ever better? No. Are you significantly better to the point that you can function the way you would like to function? For these patients, the answer is no, because none of those therapies deal with the fundamental problem, which is tight freaking muscles. Our therapeutic priority for IC subtype 3 is to restore circulation. We don't give them bladder therapies first. We restore blood flow first. How do we do that? With pelvic floor physical therapy. And the research proves the pelvic floor physical therapy is stunningly successful at reducing the symptoms of IC. And again, that's a National Institute of Health study from 2008. So if you're somebody where you have been doing bladder therapy after bladder therapy after bladder therapy, and you're not that much better, and you've never had a pelvic floor assessment, it is time, my friends, to go have a pelvic floor assessment. Let us see if your muscles are part of the problem. It is possible. I now realize for me today, at the age of 60, I started the IC Network when I was 33. I don't even know how this happened to be older, but my bladder wall has healed. My bladder wall is completely healthy. There's nothing wrong with it. When I had my hysterectomy, they looked at it. It's fine. My problem is my pelvic floor. And that may have been the long-standing problem that began in childhood because I have scoliosis, because I did have frequency urgency in school. Okay, so my therapeutic priority for my body is absolutely to work on those muscles. And when I work on those muscles, guess what? Things get better. All right. IC subtype 4. So here we go. So we had a bladder wall injury, then we had a muscle injury, but now some of you might have a nerve injury, also known as pudendal neuralgia. So if your symptoms are positional, you're fine when you stand, but when you sit down, it hurts. Or as Andrea says, Andrea has electrical shock sensations, that electrical burning, buzzing. That tells us that a nerve is involved. And so Andrea here on YouTube says, I went for a pap smear this week. I was in agony the next day. The pain was excruciating. I had electric shock sensations that were debilitating. So Andrea, clearly, somehow, either what happened is maybe they either pushed on a nerve. I mean, because normally when they do that exam, they put the speculum in, they then do the pap smear, then they pull the speculum out, and then they put a finger in and they start touching things. So either, number one, when they did that, they actually touched a nerve, or more likely, it was painful and your pelvic floor muscles got tight in response to that pain, and perhaps got so tight that they were now squeezing and traumatizing that nerve. The bladder wall does not give electrical shock sensations. The pudendal nerve gives electrical shock sensations. I hope it's calmed down, hun. You need to call them and let them know that that happened. And if you can, it would be very interesting to see if maybe using a little bit of heat to try to relax muscles. That's hard because with nerve pain, you kind of want to do cold. Andrea says, you are right, Jill. Yeah. Okay. So to try to get, and it has calmed down now. Good. Excellent. Excellent. So if you have positional symptoms, you're fine when you stand, but when you sit down, it hurts. Or if you have a vibration like I have right now sitting here, it just started in the last 15 seconds. When I sit too long, my pudendal nerve in my left butt cheek starts to flutter. It's a movement. It's a sensation of movement. It's like sitting on a cell phone and vibrate. And that is from the pudendal nerve. So our therapeutic priority for this group of patients is going to be, number one, to calm the nerve. So they might be giving you lidocaine or some sort of topical that will help calm where the nerve is irritated. But even more importantly, we want to try to figure out where the nerve is compromised in the first place. My nerve is compromised because I have a tight piriformis muscle that is trying to keep my SI joint together, because ultimately for me in the end, it's all about my SI joint, my scoliosis as being being the reason why I have long-standing issues. Okay, so IC subtype 4 is a nerve injury. And again, you can read about all these on our website. Let's go to the last subtype. The last subtype is, I think, the most interesting subtype. It's called central sensitization. So this is a subtype that's inherited. I'm a redhead. This is me. It's characterized by really sensitive skin. We have a sensitive stomach. We have a sensitive bowel. We have a sensitive bladder. It's easier to give us pain because our nerve thresholds are lower. We have a wicked sense of smell. We can smell things that other people cannot smell, and smells drive us crazy. My sister is an award-winning winemaker, and she has central sensitization like I do. And one of the reasons why she's such a good winemaker is she can smell more. We can taste more. Our bodies are wired a little bit differently. If you go back thousands of years, we were the people who could tell the tribe that the water was safe to drink because we could smell if it was good or bad. This is not a disease process. In some cases, this is inherited, but in other cases, this happens after trauma or injury. You know, those people who injure a knee badly, 20 years later, they can tell when a storm's coming in because their knee starts to ache. I mean, bones heal, muscles usually calm down, but ultimately in the end, when nerves get injured, they become easier to turn on. And that at least for me, that's lifelong. It makes sense. So my therapeutic priority is always going to be to calm and soothe my nerves and to stay out of situations that will trigger my nerves. So I don't like traveling very much. Traveling will always trigger stress for me. It will always trigger IBS and bladder sensitivity. I'm never happy traveling. I prefer to stay at home. I prefer staycations or staying local rather than flying. High periods of stress are going to do that. Lisa says, can you have more than one type? Absolutely. Yeah, definitely. But do you see the point here? It's not about one treatment that's going to make everything go away. This is about figuring out what's triggering your pain, where it's being triggered, and treating all of those. With central sensitization, it's like fibromyalgia. When you got fibromyalgia, you've got altered nerve processing, so you can have pain all over your body. Well, the same kind of applies to central sensitization. For me, I will get random pinpricks in my arm, in my leg, in my hip, just randomly. Like, what? It's like you feel like you're being bitten, but you're not being bitten. And that's classic central sensitization. And so our therapeutic priority for this group is to calm nerves down. And the most exciting thing that we have right now for central sensitization is palmitoethanolamide, Piora. And all of the research studies have been done with PEA, and there have been dozens done in Europe for fibromyalgia, sciatica, burning mouth syndrome, IC. PEA has been found to be the most successful for people with neuropathic-driven pain. And so this is what I take. I don't take a bladder wall therapy because my bladder wall is fine. Although as I get older, my bladder wall might start getting funky because of estrogen atrophy. But for now for me, my goal is to try to keep my nerves fairly calm and to work on muscles that get tight. Marisol says, is there a supplement you offer that helps with rebuilding estrogen? No. There are a lot of, soy-based supplements that are over the counter. We certainly don't sell any. And the reason why is because most of them come from China, and I'm very, very uncomfortable with that. If you've got estrogen atrophy, you have to talk with your doctor about it. They've got to study your body. They've got to study your skin and see how severe it is. And then they base their therapy based upon what they see. It's easy to see estrogen atrophy. It causes kind of lines in the skin. You and I can't see it, but they can see it. And so generally, estrogen atrophy is treated with a topical estrogen product of some type. Susan Wright says, what about sway back of Lord? Okay, so there are a group of patients who, no matter what you do, their pelvic floors are locked down tighter than a drum. And you can go to pelvic floor physical therapy and they might be able to get those muscles relaxed, but a day later, a week later, a month later, the tension is back, the trigger points are back, and they're always back in the same place. And that's where this book shines. Anybody? Oh, where is it? Here it is. The book of books of books. The book that, in my opinion, everybody should read is this book, Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss. Because he introduces a new concept, very new to the IC world, that finally just makes totally sense. So getting back to, what about these people whose muscles are just it's so tight? It's like, he was very frustrated. This guy is a master at getting rid of trigger points. He's a master at calming muscles down. He's a master at calming nerves down. What baffled him was, why was the patient back a month later with exactly the same problem? And that's when he introduced the concept of a mechanical injury. That sometimes there's a reason why muscles are constantly chronically tight, and that is because there's a problem with bones. There's a problem with movement. Do you have a bad hip? Do you have a bad SI joint? Do you have scoliosis? Do you have a bad knee? Do you have a bad foot? Because how you walk is going to influence your pelvic floor. We have one lady that I worked with here in the IC world, and I don't remember her name, so I'm not going to say, but in her case, she has a really significant birth defect on one foot, and she cannot walk normally. Even with help, she cannot walk normally. And her pelvic floor is as hard as a rock. And muscles are not meant to be hard. They're meant to be loose and light and pliant. Because remember, blood has to flow through them. Blood is not going to flow easily through a rock. Your muscles are meant to be long and lean, not popped like that, right? So for some of you, there is a mechanical injury. Kara says, how do you get tested for fungus? You get tested with a next generation DNA urine test. Or the doctor might have another test that they can order. So if you have long-term tight pelvic floor muscles, that's when we got to take a step back and go, oh, wait. And watch you walk down a hallway. Do you walk normally? So a brand new study came out this summer. Men with testicular pain and prostate pain and scrotal pain. 70% of these men had a problem with their hip. And when they went to orthopedics and when they were referred to orthopedics, what do you think happened? Things got better. And that's exactly what we're seeing in the IC world. This is how things have changed. We no longer think of IC as an incurable bladder disease, my friends. Yes, for some of you with Hunter's lesions, there might be an issue. But a lot of you, in fact, the majority of you, actually have perhaps muscle stuff going on, bony structure stuff going on. If sex has always been painful, if you've dreaded having an annual gynecological exam because your muscles are tight, you have vaginismus. This could go back to a childhood injury of falling on your tailbone. We see a lot of tailbone injuries. It could go back to bedwetting. If you were a bedwetter and you had a parent who beat you for wetting the bed, it's happened. Yeah, you could have locked down your muscles when you were a kid and you've never released them. Your muscles have been locked down for decades. But it can also be the result of trauma, accidents, anything, a difficult childbirth, anything. But most of all, what we're seeing is a lot of tailbone injuries. So this Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss is fantastic. And some of you have gotten it and then you haven't read it, or you've skimmed it and then you've called me and I can tell you haven't read it. You know, it's like, okay, go back to chapter 1. Do you see where the nerve is? Oh, okay. Yeah. Go back and read it. This, you got, man, you're back in school with this book. I want you to study it. I want you to study it. Look at that. I wrote, yikes. What did I write here? While practitioners focus on the bladder, an unfortunate chain of reaction is occurring. The dysfunctional muscles further tighten and weaken, causing the surrounding muscles to work harder and become dysfunctional as well. Eventually, trigger points in the stressed muscles are activated and become tender, quite possibly placing pressure on the nerves, supplying them. The engagement of the nerves causes another more challenging level of pain. Trigger points in the nerves they irritate are now generating pain that, if allowed to persist, sets in motion a neuroplastic process that produces pathological hypersensitivity in the central nervous system. Hello, central sensitization. And the sensitized system responds by lowering the pain threshold and spreading, maintaining, and prolonging the pain. Hello, 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 hello. Look at what I wrote. Yikes. This book is free on Kindle Unlimited. No excuses. It's free. You can sign up on Kindle Unlimited for a month, download the book, read it. Please, please, if you've taken Elmiron for 20 years and you're not better, you need to get this book and read it. There might be something else going on. Ruth says, is it safe to take Sister Project, Bladder Build, and PR at the same time? No. Why would you do that? Pick one and start with one. I would start with Bladder Builder first, because Bladder Builder has the most in it that can help. And then if that's not quite enough, you could potentially add the Piora. But I wouldn't take the Sister Project and the Bladder Builder at the same time. More is not better, guys. We're sensitive. Do one at a time. Cara says, what can be done if it is from a tailbone break? Well, it depends upon how the tailbone heals, hon. If the tailbone heals crooked, chiropractic might be somewhat helpful, but you might have to talk with your doctor. They might have to just really emphasize those those muscles, to try to get things to straighten out and behave normally. But tailbone injuries are big. All right, so listen, I've gone over. We need to start the Zoom meeting here, but let me just go through some of these and then I'll start the Zoom meeting. Tammy says, oh no, I'm simply just going to find a new doctor. This urologist of mine is not the right doctor. He smirks at me and shows no compassion. I hope to find a compassionate one. Tammy, we have a doctor list on our website, icnetwork.org. You can just go right there and look at our list. Libby says, a Q-tip vaginal exam and how my doctor diagnosed me with vestibulitis and hypertonic pelvic floor. Yeah, it's one way of doing that. Sarah says, I take over-the-counter Cystex with one aloe pill. It works okay, just okay, not fantastic. Yeah, Cystex is not meant to be taken over the long term, hun. It's really not a therapy for IC. We've had patients who had issues. There's one patient in particular who used it for about a year and developed, and I don't remember what it was, but a very serious medical condition because she overused Cystex. So I would pass on the Cystex, and instead I would look at some of the legitimate supplements. Libby says, there's someone falling on top of you in a mosh pit. Sarah says, I had H. pylori. Have you ever heard of any correlation? The answer, that's a good. It's kind of interesting and good because it somewhat mirrors the urinary tract. Many people thought for years that the stomach acid was so strong that no bacteria could live in the stomach. And they always thought stomach ulcers were just from too much acid. And it was a doctor in Australia who made the discovery that no, Helicobacter pylori actually can live in the stomach and in fact cause stomach ulcers. And he was laughed at and mocked by other doctors. He eventually, I think, didn't he win a Pulitzer Prize for that discovery? He might have. But medicine in general laughed at him for years. Nobody believed it until finally we had better testing, like next generation testing, which could confirm that. And the same is true with the bladder. For many years, people thought urine was sterile, that there was nothing living in urine. But now we know that's not the truth. Now we know that there are thousands of things that are living in the bladder appropriately and correctly. And so that's, again, where antibiotics have done so much more harm than good, because that's wiped out the good bacteria. And it's next generation testing, which has been done now for about 10 years. All the big research studies with IC use next generation testing. That's what's helped us reveal and understand what is supposed to be in the bladder. All right, man, can I talk or what? Ina says physical therapy is not enough if your nervous system is sensitized. Well, physical therapy is critically important because we have to get those muscles to release. But if a nerve is compromised, they might want to do things that will calm that nerve down. And he talks about that in this book. That was a big part of his examinations, was because he believes that a lot of people have more nerve involvement than they realize. And so he would absolutely look at the skin. He's looking for pins and needles, looking for any changes of characteristics in the skin, like lichen sclerosis, where skin turns white. We're really looking for anatomical changes suggestive that perhaps nerves are involved. And then he would do a very aggressive, robust therapy program for that, where he would give patients a topical anesthetic to calm the nerves down. And he would also even maybe inject lidocaine into the subcutaneous tissue underneath the skin if the nerves there were inflamed. And he was the first to do that. And so Libby says pudendal neuralgia is pure hell. It is. Tina says, has anybody looked into a chronic embedded infection that can be cured by long-term antibiotics? So Tina, I will tell you that as Curtis Nichols said in his most recent lecture to the AUA, to the American Urology Association, which is 20 to 25,000 urologists who gather around the world once a year to talk about all the research. A good portion of the early IC research studies done by the National Institutes of Health were done to look for that. They threw every test that they could at IC urine, IC skin, and they simply did not find a common pathogen. It would be nice if we could say, yeah, a Helicobacter Jill Osborne, if found in the urine, is a cause of IC, but they've never made a discovery like that. Now, there has certainly been a very robust group of people who believe that every IC patient has chronic embedded infection. They are wrong. They are wrong. The challenge here is that if you spend time with patients like I did, and you ask patients, what triggered your symptoms? Many of them said, I fell. Or many of them said it was immediately after I had surgery. Or many of them said it was after I had a baby. Or chemotherapy. I mean, the best example is probably the chemotherapy patient. Chemo is very irritating to the bladder wall. Absolutely very irritating to the bladder wall. It gives you all the symptoms of infection, frequency, urgency, pressure, pain, but it's not infection. It's chemical injury to the bladder. And right now, there's a very vocal group of people coming out of England, as well as some in the US, who believe that it is embedded infection that no test can find. And basically, they just throw antibiotics at you for the long term. And the problem with that is that it destroys the biome. It creates gut dysbiosis. Taking an antibiotic is like taking a flamethrower to a forest. It kills everything. And beneficial bacteria is crucial. Beneficial bacteria control fungus. Now we know, think about it. If there's any group of patients completely overexposed to antibiotics, it's us. Because we have all the symptoms of infection, frequency, urgency, pressure, pain. I took massive antibiotics when I was younger, massive. And yet, in hindsight, I probably never, ever had the infection they thought I had. And so today we do antibiotic stewardship. Today we're trying not to throw antibiotics at everybody. We're trying to prevent C. diff. We're trying to prevent fungal infections. And that goes in the way. There's a real hard line here between the people who say it's everybody has infection versus the others who say, no, that's simply not true. I think some of you could have infection, and that's again why next generation DNA urine testing is reasonable. I don't believe in guessing. I don't believe in taking antibiotics unless you've actually found something. And if you've got something dysfunctional, next generation urine testing will find it. It should find it, especially if you had a series of them. And so you can go to bladderhealth.org, and watch a bunch of videos of doctors who use next generation testing, and they are finding weird infections in some people. It's possible. It's absolutely possible. But we cannot exclude the other things too. And as a support group leader, I will say, and as an IC patient, I've only had 2 bladder infections in the last 30 years. 2. And they were both from sex. And my bladder is completely healthy. There's nothing wrong with my bladder. Nothing. It looks like a baby's bottom. So I am certainly not a chronic embedded infection. All right, let me go ahead and take a moment and start the Zoom portion of the meeting. Logging in. Starting. Oh, wait a second. I didn't want to do that. I don't need to do that. All right. Start the video. All right. So let me get the invitation for this. All right. So, you guys, for the Zoom portion of the meeting, you will have an opportunity to talk to me and ask questions, but everybody is going to hear you because Facebook and YouTube will still be on. They're going to hear you through my computer. So if you want your privacy, then don't come into the Zoom meeting. But if you have questions, if you want to share your story, come in. You'll get coaching from me. You guys are going to have an opportunity to see how I work with the patients that I work with in my coaching. And remember, I'm not a doctor. I don't give you medical advice. What I make you do is I make you think about it in a different way. And so I ask a lot of questions. We're looking for triggers. We're looking for causes. We're looking for history. We're looking for all of that. Ellen says, remission for 6 years, recently diagnosed with fibro. Now I have urgency, frequency, and pain. You had chemo 6 years ago, but your bladder has calmed. You don't know what the current trigger is, except that you started Cymbalta. So Cymbalta is... it can help calm nerves down. I don't know of anybody who said that it's flared them. Eleanor, I would be more inclined to look at your age and let's see if you've got some estrogen atrophy going on. I would suspect generally for the patients who get older, what we find is they're starting to show some estrogen atrophy. All right, so I've let Libby in, I've let Maria in, guys, for anybody who wants to come and share your story, go for it. Courtney says, did you guys see how Elmiron caused problems for people? It's a big news story. Courtney, I'm the one who actually broke that story. I'm the one who actually found the research study and gave it to our medical board. And it was exactly 2 years ago this month that we launched our first study on Elmiron and eye disease. Let me, I got the, hold on a sec, let me. Look, I can show this to you. So for the people in Zoom, anybody who wants to come into Zoom, I'm going to post the link again. Please come on in. Happy to hear your stories. If not, that's okay. Hello, Becky. Thanks for dropping in. Susan, try again. Try that link again. Maybe I didn't do the full link. Try that link. Happy birthday. All right. So listen, before we go back into the Zoom portion, let's go over this for a moment, because I do think you guys should hear this. So Labor Day 2 years ago, I was doing my normal nerdy self, which was I was in the National Library of Medicine looking for new research studies that I could put in my magazine, the IC Optimist, when I came across this very interesting letter to the editor. And it was a letter to the editor from, here it is, right here. It was from researchers at the Emory Eye Institute. And they believed that they found a new eye disease associated with the use of Elmiron. And so what they wrote here was, we wish to alert readers to a concerning new observation of vision-threatening retinal changes associated with the long-term exposure to pentosan polysulfate, also known as Elmiron. We recently reported our findings of retinal pigmentary changes in 6 patients undergoing long-term therapy with pentosan. They described difficulty adjusting to dim lighting. Each patient had received a standard dose of pentosan, 200 to 400 milligrams daily, for a median duration of 15 years. Although we have yet to establish causality, the presence of these highly unique retinal findings in this population demonstrates a strong association with pentosan exposure. And it is, they say, pending further investigation, it remains unclear whether drug cessation will halt or alter the course of retinal disease. However, we encourage patients to stop drug medication. That was very revealing, because we now know 2 years later that the eye disease, it progresses even after you stop the medication. So what does it do? This is the original article. And one of the problems that we had with this article is people misinterpreted it. The purpose of this article that was published in the spring 2 years ago was to show the damage. They weren't making any statements about population. All they were doing was trying to just show the damage. Okay. And so some people got this and went, yeah, it's only 6 patients, who cares? Well, they were wrong. So all this is doing is making a case that the damage is occurring. And so these are some retinal scans over time. So here, this is early. This is late, this is later. And look, you can definitely see this, the cells of the retina changing. And then you can see with long-term use, you can see really significant changes happening over time. Now, I will tell you, I was sitting at this very desk, bawling my eyes out. I'm not lying. It's like, oh my God, because hundreds of thousands of patients have used this medication. Like, what do I do? Oh my God, what do I do? So what I did, I mean, I come from the perspective that we, the IC patient, deserve informed consent. We deserve to know, it is our right to know the risks of the medications and therapies we're taking, right? We should know. Like, would you take this if you knew it could make you blind? No, probably not. And so anyway, I'm sitting here going, oh my God, what do we do? What do we do? What do we do? And I sent my medical board a letter that weekend, and I said, all right, let's just credibility test this. I'm going to do a survey, and let me survey our tens of thousands of members of the IC network and let's see what they say. And so Rob Moldwin, one of the top IC doctors, looked at my survey. We fine-tuned it. We sent it out the next day. That survey now has 2,000 patients, more than 2,000 who have taken that survey. 54% report retinal disease. 54, more than half. the data was so stunning. I sent it to the AUA and to Phil Hanno, the chairman of the IC committee, and he says, fantastic work, which is great, and to get a nice compliment like that. We were asked to send it to the FDA to request a labeling change. And it was our data, as well as more research studies, which eventually forced the FDA to issue the new warning label. So the sad news here is that that the eye disease progresses after you stop the medication and for years. So if your eyesight is normal now and you're still taking Elmiron, you really need to, number one, go have a retinal exam, get your retinas mapped properly so that we know what your retinas look like, so that you can go again in 6 months or a year to see if your retinas are changing. Okay, because if they are, you need to get off of the medication. Everybody says, every researcher, eye doctor who's done this says it's important to get off of the medication. The FDA qualifies it a little bit more. They say talk with your doctor about the pros and cons, but clearly Elmiron is on its way out. Okay, so that's the story on the Elmiron eye disease. It was the most important story I've done. I will say that no other IC group went public with this like I went public with this, and I'm really proud of the role that I played in helping patients protect their eyesight and the data that we generated to the FDA. The first phone call I got after I sent out that email was 20 minutes later, and it was from a patient who was crying. And she said, "Oh my God, you just helped us figure out why I'm going blind." And she was the first patient I talked to who had it. And I've since talked to hundreds of patients who have had issues over the years. Valeria says, "Should I try dilators? My physical therapy hasn't helped much." Well, no, you've got to see, the problem with a dilator, hun, is that you're kind of going in blind. You're going in blind. You don't really know where you're going. You got to work with your physical therapist to figure out the area of your pelvis you got to work with first. Chrissy said, "I've lost almost all of my vision and I quit Elmiron years ago. I couldn't figure out what was happening until recently." Christy, I hope that you are in one of the lawsuits. There's a website, elmironlawsuits.org or .com. Please go over there. If you have lost your eyesight, you certainly deserve the right to ask for compensation, in my opinion. Yeah, I know. You guys make sure, listen, please go to our website, sign up for our newsletter so that you get our newsletters, or even become a member so that you get our magazine, because it's our magazine that has the in-depth stories. It's really important that you stay on top of this, guys. The IC world is changing massively. We learn new things every day. So, all right, it's time. All right, so Facebook, I'm going to minimize you. It's time to go to YouTube. It's time to go to Zoom for a moment. All right. And somebody just left Zoom. Whoever you were, please come back. Sorry, I'm a wee bit 30 minutes late on this. Sorry about that. All right, let us go first to Okay, hold on. You guys make sure you're muted until I call on you, okay? We can't have everybody talking at the same time. All right, Libby. Whoops. Oh, wait, hold on, Libby. Hold on. I muted you, and then I unmuted you, and then I muted you again. I'm trying to. Oh, Libby, there you go. Hey, girl. How are you? Boy, look at you. You look beautiful.
I'm so much better than I was when I talked to you.
Yay!
When was it? I'm so excited. It was January of 2019.
Okay.
When I talked to you.
Okay.
And you talked to me about the IC phenotypes.
Yeah.
I remember my daughter was having a test done at Children's Hospital, and you were on the phone with me. You actually told me that you had another call that you were on, and you left the call that you were on to talk to me for an hour and a half that day.
Oh, I'm so glad.
That call literally changed my entire life.
Oh,
my whole life was changed from that call. I'm going to cry. I
Oh,
was bedridden for 6 months.
oh no.
6 months I was bedridden. When I got diagnosed with interstitial cystitis, it was October 31st of 2018. And I didn't know anything about pelvic health. I didn't know anything about anything really that had to do with muscles and pelvic floor dysfunction and all of those things. But I have studied and I've taught myself so much that through your phone call that I had with you and reading Dr. Payne's phenotypes, I'm such an IC nerd now. It's ridiculous. I created the IC Advocates page on Instagram, and I created the Intuitive Advocate. And all I've been doing since I figured out what my phenotypes are and got onto the correct treatment is I literally devoted my life the last 2 years to try to help other women figure out what their phenotypes are, like you do here on Facebook, on Instagram. Because there's so many women that have no idea what is going on with their bodies. And on Instagram, we have a really big issue with the IC community. The embedded infection theory is really rampant in the IC community on Instagram. So I've been trying as best as I can to post facts, like the things that you talked about today, because it's so important. So I have pudendal neuralgia. I have phenotype 3, 4, and 5.
Okay.
I have a hypertonic pelvic floor dysfunction.
Okay.
I have severe bilateral pudendal neuralgia, which I had no idea. And my injuries were caused due to a woman who fell on top of my head at a concert when I was in a mosh pit on June 21st of 2018.
Oh boy.
No one knew. No one could figure out that the head injury that I had directly affected my pelvic floor.
Well, it would have been a compression injury, right? I mean, it's a compression injury. Your whole spinal cord from your head down was pushed down into your pelvis.
Exactly.
Wow.
And it took me, I studied the nervous system, like all 3 parts of the nervous system, the pelvic floor muscles, the bone structures. I studied the autonomic nervous system. I specifically figured out what tests to ask for from all my doctors.
Yeah.
I probably saw 20 different specialists over the course of maybe 3 or 4 months.
Yeah.
And I had doctors lie to me. I had doctors tell me my MRI results were normal. I always suggest for every single person to get their medical records, read them themselves. I offer to help anyone if they need help to try to decipher some of them because I've learned how to. And I try to help them figure out their phenotypes because I was seen by a doctor for 3.5 months who was on the MAP study. She's on the MAP study. I could tell you her name personally, but I don't want to say it in front of everyone.
Yeah.
But I saw 2 doctors that were on the MAP study. One was a professor of the MAP study. I specifically kept asking, what's my phenotype? I spoke to Jill Osmond of the IC Network, and I need to know my phenotypes. And they wouldn't help me. So it was literally just, I read. I was bedridden for 6 months.
Yeah.
When I had 3 kids. So this was, it was really, really difficult. But I got on the right treatments. And as soon as I started getting on the right treatments and doing the things I needed to do, because I figured out what the root cause, for me and most patients that I've talked to, pelvic pain is always complex. There's more than 1 or 2 things going on.
Yes.
So like I have estrogen atrophy, I have low testosterone, that affects vaginal tissues. That also causes pain. So I did hormone replacement therapy for a while. I've done pelvic floor physical therapy. I suggest anyone at least get an evaluation if you have pain, because you don't know. You might have one. The Q-tip test for me was phenomenal. I was told multiple times by doctors that I didn't have pelvic floor dysfunction, but I had all the symptoms. And it wasn't until I saw a specific doctor who literally that's what he does. He treats complex pelvic pain. He did the Q-tip test.
Yeah.
I had severe pain that literally mimicked bladder pain as soon as he touched my vestibule.
Yeah.
And as soon as he figured that out, he was like, you have vestibulodynia. He was absolutely 100% spot on everything. He's the only doctor that told me to my face, you do not have IC. IC is a blanket diagnosis. He knew what he was talking about.
So who was that?
Dr. Joshua Gonzalez.
Really? Is it?
Yes.
Okay.
Yes.
So make sure you send me his info so that we can get him added to our database.
He's phenomenal. Dr. Joshua Gonzalez.
Okay.
Then I saw Stephanie Pendergrast.
Oh, yeah.
Pelvic Health. And she is a genius.
I know, isn't she?
Literally she's amazing.
She's like she's like the best physical therapist in the country, in my opinion. Yeah.
I agree. I truly agree. So I saw her, and I will say this much. Insurance does not cover for you to see her. I highly, highly, highly recommend, if you're able to travel, if you're able to just fundraise the money to see her. The visit, I think, was $300 for an hour and a half. She was the first person to finally confirm that I knew I had pudendal neuralgia.
Right.
I knew it.
Yeah.
She finally was the only person that finally wrote it down on paper. She referred me to Dr. James Nguyen at Cedars-Sinai.
Yeah.
That man has changed my life. I just took a cross-country road trip with my husband and my 3-year-old son.
No.
23 days straight in an RV.
Oh my God.
This past summer.
That's incredible.
I've been able to go hiking again. I can walk. I can sit for hours and paint. I can do literally, I told everyone in the Facebook IC groups, I will find my root cause. I will figure out how to get back to who I used to be.
Mm-hmm.
It will take time. I am determined, and I did it.
So
people tried to convince me to get hydrodistensions. I refused.
Right.
I went with my gut. I basically asked women like 2 first questions. What does your instinct tell you is wrong with your body? Because I strongly feel that we know ourselves best. And then I start asking them questions about what their pain specifically feels like, so we can go over the phenotypes. I know I'm not you at all. I don't try to be you. I respect you a lot. I made a video at home of the IC phenotypes because I couldn't figure out how to get yours onto Facebook. And I put that on Instagram to try and help people just find the phenotypes.
Well, and see, that the thing you got to understand, I mean, there's so many important things about your story. Number one is that you had a triggering event, and it was very clear in your brain that this started after that fall happened. And guys,
correct, 2 days later.
Right. So for everybody watching this, Libby's story is critical here, because even if it was 20 or 30 years ago, you've got to think about those triggering events. The second thing that's important about your story is that you are proof that IC is a grab bag diagnosis with no intuitive treatment plan. You could have been on bladder therapies for decades and been bedbound this entire time. And you took the advice of, you are an anatomical mystery to be solved. Everybody's different. We have to understand the pelvis. We have to understand the pelvic cavity. And so you were assertive and you were firm in saying, okay, I want to know this. I want to know this. I want to know this. And are my muscles healthy? Are my nerves healthy? And going and asking over and over and over again. I always say, don't walk into a doctor's office and say you've got interstitial cystitis. That's a huge mistake.
Right.
You have to walk in and say, here is my body. Here is my symptoms. Can you help me figure out what structure in my body is causing these symptoms? Right. It's about structure analysis. It's about getting them to look at this. So clearly in your case, one of the nerves that's coming off the sacrum, right?
Mm-hmm. So I have a pinched nerve at my L5-S1.
Okay.
I have bulging discs at my C3, C4, L2, L3, L4, L5.
Right.
I have the bilateral pudendal neuralgia.
Right.
I have muscle atrophy.
Yeah.
On the lower right part of my right side of my back, like upper buttocks, lower back.
I have muscle atrophy too. Yeah.
You do. I wanted to ask you about that because no one knows exactly what to do to help me. My chiropractor is phenomenal. My physical therapist is incredible. I'm considering going back to Stephanie one more time to see what she would suggest.
Oh, I would. Yeah.
The muscle atrophy, we're not exactly sure. It's probably a combination of a couple of the muscles back there, and they connect to your sacral spine and your hips.
Right.
Right. And so my right hip goes out constantly.
Yeah.
I'm always like misaligned because my SI joint went out, but we can't do another SI joint because I know me and you are very similar. I can't do another SI joint block for a few different reasons. Number one, I have the atrophy there now. And the other reason was because, believe it or not, I'm allergic to a lot of things that people use that helps them. I can't use lidocaine, I'm allergic. Botox, allergic. Latex, allergic.
Yeah. So, okay. So again, for people listening to this, and you probably had the SI dysfunction for years, and the fall on your head just magnified everything intensely. But the original dysfunction probably goes back to whatever's going on with your SI joint. It's been going on for years. Your muscles have been weak in that area. Just like my muscles are weak in my area. What my sports therapist told me is that I had, because what they told me is that it was all muscle for 15 years. My physical therapist at the time basically said, you got to stretch, you got to stretch, you got to stretch. And I was doing it yesterday. I can touch my nose to the ground now. Believe me, I'm a master at stretching my piriformis to the point that
me too.
I know, but I overstretched it. And that's what the sports physical therapists finally figured out, is that because the stretching never made it go away. I mean, it kind of relieved some of the tension at the upper part of my glute, but the pain, but the deeper pain when sitting did not go away with that. It just worsened. And so it was a sports physical therapist who, not the internal, the external, who was watching me walk. And he said, do you realize when you walk like this? Like I was favoring one side, little arcs.
Really?
And that was because the muscles on my left side, my glute muscles, don't activate. They don't turn on.
Me too.
They
I
just
have the same problem. I have the same problem. So I've been trying to get my glutes muscles, especially on the right side, to activate.
Well,
I tried
but they didn't.
Different maneuvers.
Well, mine are activating now, but it was a long process. Number one, he told me he said I couldn't stretch for 6 months. He said, no more stretching, no more yoga, nothing. Do nothing. You have damaged everything. And so once I stopped stretching, that helped. And then he gave me just a whole bunch of exercises to do, like a dead bug. You know what dead bug is? And
I've heard of it. I'll have to look it up.
Yeah. In our last magazine, on this one, I have a series of exercises in here. I mean, our goal number one is going to be to relax muscles, but then once we get the muscles relaxed, then we have to strengthen them. So he had me do like
my physical therapist told me to start doing bridges. I started doing my shadow ones.
Oh yeah.
When I had
no, bridges. So bridges were important. Right. So what?
Go ahead.
What you and I should do offline after this, maybe tomorrow or the next day, is let's share our routines, since you and I both have SI issues, because mine is better. Mine is better.
It is.
But one of the things that he had me do is I kept hurting my knee doing deep knee bends. Right.
Okay.
And
so that's interesting, because I hurt my right ankle a few years ago, and I was in a brace.
Oh, see, that's huge.
I just remember that.
That's huge too. Let's do it.
I hurt my ankle really bad, my right ankle. It was really bad. It was 6 months before my wedding in 2014.
Okay. Well,
it's the right side. Oh my God, it was the pregnancy.
Okay, so let's do a Zoom in a couple of days, just you and I. We'll go over stuff. And then, guys, I just want to say, the last thing I want to say to you, Libby, is that I'm so glad you're doing Instagram. Because there's so many patients who need, and it's impossible for one person to find them all. I can't, and I am so over trying to do that all. I'm already working at least 60 hours a week doing IC stuff. And I just can't do Instagram at all. And frankly, we need younger people involved. you know, and so I applaud you for doing that. Keep it up. If I can help in any way, if we can do a live stream over there, but
I would love that.
sure.
I would love that. That would help so much.
Okay, so let's.
Honestly, I deactivated the IC advocacy account because I just couldn't keep up with it. But I would love to reactivate it and have a live with you on there. That would be phenomenal.
Well, we might be able to do that. So let's talk about that. I usually take Mondays off, so let's try to connect sometime this week. Okay.
Sounds great. Thank you so much.
I'm so glad you're better. I'm so glad you're better.
Thank you. Thank you for your help. Thank you for everything you're doing for us. I really appreciate you so much.
Very welcome. All right. Okay. So so I've got Maria. Let's see. Hold on. I've got some pictures and okay, let's go to Maria next. Maria, are you there?
Yes, I'm here. Hi, Jill.
Hi. Can you? Are you going to turn your camera on, or you going to go?
I will, but I'm on PJs.
That's okay.
So sorry about that.
That's okay, girl. Listen. Oh, you look beautiful. You look. I would never.
Oh, no.
I would never have known. How are you doing today, hon? How are you?
I'm doing good. I've been listening to you for a little while, and once in a while, I'm ask you questions, and you are so nice to answer. I would love to hear your opinion about my situation.
Okay.
I was riding a bike back in September of 2019 up to a hill, and shortly, a few days after that, I started feeling something on my left butt.
Yep.
My butt cheek, something like it was not normal.
Yeah.
And discomfort sitting down.
Yeah.
So it kept going worse.
Yeah.
And worse, and I didn't know what it was. I started doing a bunch of tests, and it took from September 2017 that it started to December 2017 for a physical therapist to tell me that what she thought I had, after ruling out so many things, MRIs and, colonoscopies and all that, that she said that she thought that I had pudendal neuralgia.
Yeah. Yep.
Yeah. And I started my treatment in February 2018. I went to see a doctor in Tennessee, which probably you've heard, Dr. Jernigan.
Barry Jernigan?
Yes.
Yeah.
So he told me that, it looked like you have pudendal neuralgia. You probably, he thought I don't have entrapment, that I probably have irritated or damaged a nerve.
Yeah.
And when he went in to do my Botox injections on my pelvis muscles, because everything was so tight.
Okay.
And he did the Rio injection, which is the amniotic fluid, into the canal where the nerves come out.
Yeah, the Alcock's canal. Okay.
Yep. So that itself made me improve a little bit.
Nice.
And I waited a year, and he sent me to one of his friend doctors here in Orlando, Florida.
Okay.
Who to do the second treatment. And the new doctor, which is Anthony Gunn in Orlando.
Okay.
He didn't want to do both at the same time like the doctor in Tennessee did. He wanted to see which one will work best for me. So he did the Botox first. It helped, but not really. I still had the discomfort. The most important thing that he told me to do is the physical therapy after the Botox. Because the Botox will run out.
Right.
And I needed to work on muscle memory.
Right. Right.
So then the third treatment was just the amniotic fluid by itself. So I had so far 3 amniotic fluid injections to the nerves and 2 Botox.
Okay.
And the doctor in Tennessee, when he did the very first treatment, he looked at my bladder. Okay. And he showed me pictures with those red spots like you just showed earlier today. And he said that I had IC. So he put me on Elmiron. So I took Elmiron for 2 years. The first year I was strict. I took the 300 night and evening. And then the second year, I was not so very strict to medication because I started feeling better. As of today, sitting down, I don't think I'll ever be normal because I think I have something in one little spot that when I sit down, I feel it no matter what. And now that my muscles are relaxed, I can control it by using suppositories or compound medication with it's a mixture of muscle relaxers and gabapentin.
Okay.
So I use that at night.
So is that a vaginal Valium suppository?
Yes, but I use it rectally.
Okay.
Because my problem is more in my butt near me.
Okay.
In my butt when I sit down.
Okay.
So now I can sit down, but it's a discomfort that is always there and it doesn't go away. I've kind of learned to live with it.
Does it ever change? Does it change?
Oh yeah, it can get worse if I sit too long.
Okay.
If I walk too fast or too long.
Okay.
Because walking to me is no problem. And now with this problem, since I started, 90% of the day I stand, and I got used to. My body has gotten used to it.
Okay.
So I have my standing desk that I work every day, 8 hours, and sometimes I don't sit the entire 8 hours. I'm so used to it that I sometimes eat it standing. But I can now watch a movie and recline and watch it, but I have to reposition myself.
Okay.
And so on. But the IC, I went back to the doctor in Orlando, and when he did the third injection of the amniotic fluid into my nerves, I asked him to take a look at my bladder again to see if the Elmiron had done anything for 2 years. So he did go in there, and he told my husband, because I guess I was a little bit drowsy, that it was slightly worse. So apparently the Elmiron did nothing. So when you show those pictures, I have those red spots, like you mentioned.
Yeah.
Okay. And this is before it's filled or after it's filled, but then I don't know. I have the red spots. And
but that's a pretty good looking bladder right there.
Well, what is this? One picture is like this. I don't know if that's when it's filled or before it's filled, but this is the one that has the red spot.
Well, so the before is the first one, the after is the red one.
Okay.
But remember, what I don't understand are the bumps on your bladder wall and the upper left one. That's kind of interesting. I don't know what that is. But that's looking like a pretty. Well, I don't know what I don't that upper left picture is kind of weird. I would ask what that is. I have no clue what that is.
This is like little bubbles. This one?
Yeah.
Yeah, it has like little bubbles.
Okay. So maybe it's just fluid or something.
Yeah, it looks like water.
Okay, so I want to show.
The concern is the red ones. Look at the red ones.
Right. So you too, like Libby, ultimately in the end, you are a pudendal neuralgia patient.
But let me tell you, I don't have frequency.
Right.
I do not have the burning sensation when I pee.
Right.
No. What I do feel once in a while is burning when I just stand up. I feel burning some down there, and I don't know where it comes from.
But is it the electrical burning you associate with the with that spot, or is it a deeper burning? Is it? I mean,
it's a slightly burning. Doesn't let me stop my day. It's just a slightly burning with tingly that comes and goes. Okay. And what I do get is a lot of bloating. My stomach, my belly bloats like I'm pregnant. And when I go to the doctor and they press.
Here, hold on a sec. Here, sorry, somebody came in and had their thing on. All right, keep going. So you have the bloating.
So the bloating is the number one symptom that I get once in a while. And that little tingly burning sensation that eventually goes away. Once in a while, I take that medication that is for the inflammation that makes you pee in colors like orange or blue, whatever.
Yeah, pyridium. Yeah.
And
okay, so let me show you a picture. I want to show everybody this picture. So this picture shows all the branches of the pudendal nerve. So I don't know if you can see everything in yellow here.
Yes.
Right?
Yes.
And so you can see that the pudendal nerve basically starts in the rear part of your body, and then the nerves move forward all the way up. And they have several branches. So you can see that you've got a branch that goes by your rectum, you've got a big branch of nerves that go by your perineum, et cetera, right? Okay. So now let's look at all right, where did it go? Come on, I just put a thingy on it so I could get to it easy. I want to just show you what a bicycle seat did.
Yeah.
Okay, here it is. So now let's look at what a bicycle seat does. So you can see the bicycle seat pushes directly up into those nerves, right? And so there was just yet another new study that was in the AUA. Oh, here it is. And it was specifically a study about women cyclists. And I put it in the magazine. Where is it? Hold on. Let me find this real quick. Here it is.
Just confused about what I have.
No. No, you have pudendal neuralgia. Look at the title. Pudendal neuralgia linked to bikes.
Yes, I know it's called the cycling disease. Okay.
There is a long association between cycling and numbness in men, but does this also happen in women? This research study surveyed 875 female cyclists. 44% who reported genital numbness, with greater prevalence reported in the younger cyclists. So that was interesting. The younger patients had more numbness. And a low handlebar rather than a high handlebar was associated with more numbness and nerve dysfunction, because when you have a low one, you're just bending over and you're putting...
Now, both doctors have told me that I see that my lining is very thin.
But you're older now, so you could have some estrogen atrophy. You could have,
That's one of the first GYN doctors, before anybody told me I had pudendal neuralgia, sent me home with a tube of estrogen and told me, use this because you need it.
Right. Okay. Well, but I
didn't believe it.
Well, but that's aging. And the reality is on the inside, we're all feel very young. At least I did. When they gave it to me, I didn't believe him either. I didn't use it until I started having pain. And he chastised me and he said, a year later, why didn't you use it? And I said, because in my brain, I'm 25 years old. I can't possibly have an age-related issue. I was 51 at the time. And so again, there are three distinct things happening with you. Number one, there's no doubt you have pudendal neuralgia. There's none at all. And there's no doubt that you have pelvic floor dysfunction, because that is what normally causes pudendal neuralgia. And the fact that you get better using a vaginal Valium suppository tells us that when we relax those muscles, things feel better.
Yes.
Your bladder wall involvement is either due to estrogen atrophy, or it might also be due to the fact that the somatovisceral reflex, that your muscles have been tight for a long period of time. They have restricted blood flow to the bladder. They have caused a lot of nerve inflammation that eventually gets to the bladder wall and causes the bladder wall to break down. And I've talked about that before, and this book talks about that. It's a somatovisceral reflex. So in the end, what you've got to do, here we go. Christy on Facebook says, I'm a cyclist and a bike racer. I have to put 5% lidocaine on just so I can ride my bike. Christy, yikes.
I don't want to ride a bike ever.
No,
again in
I
my
won't.
life.
I won't. Because now that I have a confirmed pudendal nerve entrapment, and my nerve entrapment, getting back to this picture, I can tell you exactly where my nerve entrapment is. It's in a little arc.
Like to confess to you, my whole life I've drunk diet sodas. I use a lot of, the sugar substitutes.
Yeah.
So, I coffees. So I don't even know if it's the diet.
No,
or if
hun,
it's
no,
the
listen,
estrogen
stop it. Stop beating yourself up. No, stop it. Listen. Number one, none of this is your fault. You have done absolutely nothing wrong. There is no shame. There is no blame to be had here for anything. Okay. So stop beating yourself up. You are not the problem. And you never were the problem. And when you were younger and driven and drinking Diet Coke, your body could handle it because you had a lot of estrogen. If you were drinking Diet Coke today, older, I would say that would be fairly stupid to do, but we know more now. But what we do know is that your dominant issue that makes it difficult for you to sit is, in fact, a pudendal neuralgia. And that's where you have to spend your time. And yes, you and I are older. And yes, our bladder wall is more vulnerable. And yes, doing things that will help our skin, like using topical estrogen, like following the diet, maybe like doing a chondroitin-based supplement, makes sense. But, there's good news in this case for you because number one, we know you have a pudendal neuralgia. We know physical therapy is important for you. We know the topical vaginal Valium or rectal Valium is effective for you. And I guess
I learned the exercises. I get a massage every week.
Oh yeah, it's so important. But I think
I
think what would be interesting for you would be fascinating to see how you did with something like PEA. Which in all of the
bladder.
No, this
builder?
is Peora.
Peora?
This is just the PEA and the resveratrol. So this is the formula that was used in the study. There's nothing for the bladder wall in here. This is just the nerve calming agents of PEA. This might be fascinating to try, or
so I should try that before I try the bladder builder, or can I try both together?
No, because bladder builder has PEA in it too. So, one or the other, but it would be interesting to try. I mean, at your age, doing something that would protect your bladder makes sense. So something we can do.
So pick one of the other one.
Yeah, I think maybe the bladder builder to start with, because you do have some estrogen atrophy going on. So doing something with chondroitin would be helpful. But I think the PEA is the most important ingredient for you and I personally.
So the last part of my story is October 7, I'm scheduled for another amniotic fluid injection, and the doctor wants to do it now put it inside my bladder instead of in the nerves, in the canal. He says that it will help me with the inflammation.
I don't have any experience with that at all.
Yeah.
None. If you could get a little bit more information and email it to me, I'd be happy to look at it.
Of the information to your email address.
Okay.
It's on the website, right?
Yeah. icnetwork@mac.com, or you can email me right through the website. Or you can just call me too. For anybody out there watching, guys, the best way to get a hold of me, honestly, is either by email or phone. Don't send me Facebook messages or anything like that. And if you send me an email and you don't hear from me for 3 days, call me, because that just means I'm inundated. And no shame. Don't take anything personally. To everybody listening to this, don't take it personally if you don't hear from me right away. Okay.
I'm going to try that bladder builder that you suggested, and I'm also going to start using the estrogen that the doctors keep giving me.
Well, and I'm
going to try that.
But see, yeah, definitely. That's a no-brainer. I mean, that's a no-brainer. Yeah. You should search for genitourinary syndrome of menopause, and look at the other symptoms associated with that and see what it has to say. Libby's saying endo. That sounds like endo. I don't know what
I don't have endo.
Okay.
No,
Okay.
no.
All right,
it's
hon.
just bloating that I get.
Well,
Okay,
the
this is
bloating.
great information.
Remember too that sometimes the icy belly is from inflammation, and sometimes sometimes it can be from carbs. You know, like yesterday, I ate a whole bunch of carbs. I made chicken and dumplings. Then I had a cinnamon roll, and then I did carbs yesterday. I don't know why.
So carbs can inflammate your bladder as well?
Well, yeah, anything no, what carbs do is they feed yeast, which then can cause the bloating.
Yeah.
And so I just find that when I eat a lot of carbs, I get a lot of bloating. So just, I don't know. I mean, hon, it's, I think hopefully I've just given you some questions that you can ask your doctor about. Okay.
Yes. Thank you so much.
You are very, very welcome. It was very nice talking with you. And I love your pajamas. They're beautiful.
Oh, thank you. Thank you.
Okay. Lisa. Where are you, Lisa?
I'm coming.
Lisa, I love your profile picture. Woo!
Thank you.
We are going to embrace our hotness.
Oh my God, that is actually not me. I wish that was me, but it's similar to me. It's kind of a joke.
There you go. Okay.
Thank you. And thank you for everything. Oh my God, I am actually a hunters person.
Okay.
So I was going to ask the question about the multiple types because I kind of have backed into ice. I don't know how to explain this. I got very sick in 1999.
Okay.
I had a fall, a trip and fall, and I had a head injury.
Okay.
And after a wrist surgery, I woke up with a flu and a migraine that kind of never went away. And then, long story short, I ended up with chronic fatigue, fibromyalgia.
Yeah.
So after that, second was Hashimoto's.
Yeah.
Then all of a sudden, I was getting recurring urinary tract infections.
Okay.
I started seeing a functional doctor who didn't believe in antibiotics.
Okay.
Ever.
Okay.
So I had a bunch of untreated UTIs and I was getting over medicated. So I was living in Florida at the time and I went to a urogynecologist who diagnosed me with interstitial cystitis but never did a cystoscopy. So I was getting bladder installations, but I was getting infected in the office.
Okay.
And again, not getting treated with antibiotics.
Okay.
So I recently moved back. I'm in New Jersey, just outside of New York City. I'm working with an amazing chronic fatigue specialist who is finding a lot of CFS or fibro people are coming up with IC.
Right.
Almost like it's an autoimmune. I ended up finally I went to a gynecologist who said he specialized in IC. And he did a cystoscopy in the office with no anesthesia, followed by a hydrodistension. I thought I was going to die.
Well, yeah.
It was the most pain I would ever have been.
Right.
And that's when they found out that I actually had the hunter's ulcers.
Okay.
But the other thing is that I went through early menopause. So I went through menopause at 37. I'm now 54.
Okay.
So my estrogen levels, my hormone levels are horrendous. I was on GHRT for quite some time. But I never, no one ever did this Q-tip test. My pelvic floor was never checked. I'm like listening to this and I'm going, how many of these types could I possibly have? Because I think I have at least 2.
Well, so number one, don't assume that you had a lot of infections. I said this earlier. The bladder only knows one language: frequency, urgency, pressure, pain. So,
right, but I was testing out.
What were you testing positive for?
I don't know exactly. All I know is they were doing stick tests and they said I had a urinary tract infection.
Well, but that's not okay, but that's not necessarily meaningful, because all a dipstick test is going to test for is, number one, blood in your urine, leukocytes, and then number 2, nitrites. Leukocytes happen with injury. Nitrites only happen with bacteria. And so you kind of have to throw out that data at this point in time. The proof is in the pudding, and it would be absolutely fascinating for you today to have a next generation urine test, just out of curiosity, just to see what the hell's in there. I mean, it's just data. I like data. It's just science. I mean, it's just.
I'm with you. I'm actually in the middle of a flare right now. And again, like the previous person who was speaking to, hi, I look like I'm pregnant. I get so distended.
Yeah. Well, so a next generation test would be an interesting piece of this puzzle. Having your muscles checked would be an interesting piece of this puzzle. And, do you have pictures of your Hunter's lesions? Do we know what they look?
Not. I have to get them from this. Like, okay. So the other thing was he did an intravaginal ultrasound.
Okay.
In the office, and again, which was extremely painful. Now, I do not have endometriosis, but I did have 2 gynecological surgeries. So this was also, my chronic fatigue specialist freaked out because I was bedridden.
Yeah.
And he basically turned around and said, well, you know what? I think you have adenosis and possibly a tilted uterus. So you know what?
Here, hold on a sec.
Oh, there you are.
Yeah.
So he's like, let's just do a hysterectomy. Like, you're not using it and you'll be like in and out. No problem. We'll just take it all out. And my chronic fatigue specialist was like, you are in no condition for surgery.
Yeah.
Like,
Well,
there's a little like jumping the gun there. So I need to find a new doctor.
Well,
quick.
Yeah, there's a website called the Chronic Pain Research Alliance, which is the big team of researchers that are trying to understand why all this happens and the sequence of events that happens. And I think that you would find that website very interesting because clearly you suffered a major trauma. As a result of the trauma, your nerves became hypersensitive. You then ended up with chronic fatigue and fibromyalgia, which is, fibromyalgia specifically is that altered nerve function where you feel pain more easily. And then
actually, I think honestly, I don't like fibro as a diagnosis. Like, I think it's a garbage can.
Well, but it's more about. It's more about
pain,
fibromyalgia. Okay, that's good. Yeah, that works. But it's also about nerve sensitivity and nerve dysfunction. That your body is wired to be more sensitive. It's easier for you to feel pain, and that is a nerve sensitivity. So I think all you can do at this point in time is, and like, it's too soon to talk about therapies for you because we really don't understand your biology yet. We don't understand your anatomy. I think it would be very interesting to have a pelvic floor assessment because
I'm writing this down. It was Chronic Pain Research Alliance.
The Chronic Pain Research Alliance, I think you would find very, very interesting. Some of their research is very interesting. But even more so, I think having a muscle assessment would be fascinating, and having a next generation DNA test would be fascinating to see what they find. And
and I also have scoliosis. So when you said that too, I'm like clicking on all the. So I was the one who asked, like, how many types can you have?
Well, no. But see, in the end, it's all centers around muscle health. And if your pelvic floor muscles are super, super tight. And that's what scoliosis sometimes does, is it messes your muscles up and they get super, super tight. Focusing on those muscles to restore blood flow, to calm the nerves down is going to be a really big priority for you. So I think that's your homework, is to see if you can get somebody to check your muscles out and see if you can maybe have a next generation test, just out of curiosity more than anything else, just to see if there's.
And what about the lesions? Like, he mentioned surgery.
Well, so there are 2 theories with lesions. Theory number 1 is that it's a viral infection, because it was researchers in Europe that first found a very specific virus in the urine of patients with IC called polyoma virus. The polyoma.
What is it called?
Polyoma. You can find it over on our website in our discussion of Hunter's lesions. So
Okay.
they found the first virus they found was the polyoma B as in boy, K as in Kelly virus. And the polyoma BK virus is a virus we all have. It's part of the biome. It's normally silent, but it gets turned on in people who are immune compromised. Polyoma BK is strongly associated with what we call hemorrhagic cystitis. So if a hemorrhagic cystitis is cystitis that bleeding. And so we see hemorrhagic cystitis, for example, in people with severe autoimmune disease or people who have had kidney transplant where they've had to suppress your immune system so that your body doesn't reject the kidney. That somehow turns a polyoma BK virus on, which then triggers an infection of the bladder wall, which then triggers bleeding of the bladder wall. So
I would probably show antibodies if it was reactivated, right?
Well, you could potentially have so in the next generation DNA testing, there are a couple of companies that do it, and they can do a viral next generation test too, but you have to ask for it. I'm trying to remember the name. I mean, Microgen, which is the company that we work with, does the fungal bacterial for $199. You'd have to call them to see how much the viral scan would be. So theory number one would be to check that out. I don't know. I mean, it's a guess. Epstein-Barr, they've now found the Epstein-Barr virus in the urine of IC patients, and then the new MAP Research Network study that came out a couple months ago found polyoma BK, but they found another one, the polyoma JC virus, and that was interesting. And they weren't differentiating with.
What was it again? One more time. Polyoma what?
J as in Jill, C as in Kathy.
Got it. Okay.
And that study led them to believe that some IC patients have a chronic recurring polyoma BK, a polyoma infection. And I'm trying to remember. I have a couple of the new research studies on Hunner's lesions in here, but let me find that one study. Let me see. I think it's in here. Well, anyway, I've got studies coming out of the brain right now at this point in time. Oh no, you know why it's not in there is I haven't written it up yet. That's why I haven't written it, because it's that new. So, you know what baffled me is when all the European viral studies were coming out, the Americans were very silent. The Americans were very, very quiet about it, and it's like, guys, come on, this is important. What we didn't know was that the biggest IC research team, the MAP Research Network, through the National Institutes of Health, embarked on their own viral studies. And it was a small study, but they too found polyoma virus in a small population of patients, of IC patients. And what they had, if I remember correctly, I think that was a study where they had urine over time.
Okay.
I'm just not remembering all the details now, but it was released a couple of months ago. So a next gen test would be fascinating. I mean, if it is a viral infection, then they would potentially maybe suggest an antiviral, but we don't have any. I actually emailed my contact in Europe because supposedly the European guidelines scan for virus. And I said, well, what do you do when you find virus? And they said, we don't know. We don't know. So, yeah.
Well, I'll tell you this. My chronic fatigue specialist is amazing. She is infectious disease. So
good. Okay.
First of all, I already tested out for Epstein-Barr and also the stealth virus, which is HHV6.
Okay.
Which is, they don't know exactly how it's related to autoimmune disease, But she tested me for a whole bunch, and I tested it out for a bunch of bizarre viral stuff.
Okay.
So I have a feeling I'm going to see her within the next couple of weeks. I have an appointment like mid-October. We're trying to move it up because I really have not been feeling well. But she's never turned down a test that I brought to her.
Okay,
So-
well, it would be absolutely fascinating. And if you email me, I will try to find that study, or you can just search for MAP Research Network viral study. Maybe you can find it that way, but it was a new study. It might have been at AUA, but it was a pretty new study. Okay. All right, hon. Well, listen, keep us posted. Keep us posted. And,
Thank you.
and listen, hon, I mean, your case can be very overwhelming. And I don't want it. What I want you to do is you need to break it out into little manageable pieces here. And so the virus is one piece. The pelvic floor is one piece. The estrogen atrophy is one piece. And when you break it into smaller manageable sections, it won't be quite so overwhelming. We know what to do for estrogen atrophy. And
Right.
Given your history of viral infection and depending on what the next gen test finds, that topical estrogen is going to prove to be very, very important for you, I would guess.
Okay.
Well, let's see what they say. And then out of curiosity, it'd be interesting to see where your muscles are, because your muscles will get tight in response to pain. And if they're still tight, you're not going to get better until we get those muscles released a little bit. Okay. All right, hon.
Thank you.
Keep us posted. I'll be anxious to hear from you. Okay.
I would love to check in with you. I've never had a call with you, but after I go see my doctor and see what I can get tested for, I would love to give you a call.
Yeah, because, honestly, it would be really interesting to pull your doctor in to the IC lesion Epstein-Barr discussion.
Well, I got to tell you, anyone, Dr. Susan Levine out of New York City.
Okay.
Absolutely outstanding. And she is just like really there. She's just part of a $9.6 million research study for chronic fatigue ME.
Okay.
And they're now looking at histamine levels and leaky gut. I'm on a super restricted diet.
Right.
But she is on top of it. And she was more well versed in IC than my supposed IC specialist gynecologist.
Okay.
So she's been really open to it. So I suggest anyone else who's experiencing fibro pain or whatever and is in my area, if you can get in to see her, she is just beyond.
Well, make sure you send me her details to make sure I can check our list to maybe add her to our list. So, all right, I've got to go.
Thank you so much. I appreciate it.
Nice talking with you. All right, I've got iPhone. You're blonde. You're walking outside. I don't have your name because you're signed in as an iPhone. There you are.
Susan.
Hi, Susan.
Yeah, I am. I'm outside. Yeah.
How are you doing?
Beautiful out here right now.
How are you? How are you feeling? Oh, wait, hold on. All right.
Almost.
Oh, we've got some lag going on. Can you hear me?
Yes, I can hear you just fine. Like I live in Canada, so I'm quite a long ways away. But I did talk to you about 5 years ago in January of 2016, and you explained to me then that I had a bladder wall flare because I was in a excruciating pain.
Okay.
And I've had so much trouble ever since. I've tried so many different things, but there's never really been anything. I don't sleep. I guess I would give every last penny that I own to somebody if they could just get me so I could sleep again. That's the worst.
Yeah.
But what I seem to have is, other than you explained some things that I thought were really interesting here. I guess if the pain stops when you pee, and I have to pee every 15 minutes. I'm having a bad day here. It's one of these different things, and I did take some notes here while you were not very good ones, but on different pieces of paper. So I didn't.
Yeah.
I would have done better.
One
if
sec.
I'd known.
Yeah, Sierra. Hey, Sierra, please keep your microphone muted. I keep muting you, but you keep unmuting yourself. We don't want people to be able to hear stuff through your phone. When you're ready, I'll unmute you. Okay. Thank you, Sierra.
Bladder wall pain. Yeah. Okay. So yeah, bladder wall pain is relieved by peeing. So when I go pee, it stops the pain. That's one of my definite symptoms that I have this. Plus I have a lot of bloating and IBS and I got gas, really bad gas in the last, well, at least 6 months.
Are you,
now.
is it stomach gas where you're belching, or is it farting gas?
It's really weird symptoms. I guess it is IBS. It's been, but anyway.
But is it,
wait.
wait. Okay. So I'm going to do with you what I do with other people. So just let me run through a bunch of questions. Okay. Just,
okay.
Okay. So number one, are you farting or are you belching?
Farting somewhat, but it's more, sometimes it's like gas. Sometimes I press down really hard, like I have to do a bowel movement to pee sometimes, which is really weird. And I've tried to tell the doctor that. I think I just get question marks coming out of their head.
So let's go kind of go back into your history a little bit. How many years ago did your symptoms start?
Well, they got really bad in January 2016. That's when I had that horrible bladder wall flare. Really bad.
Okay, but when did they start?
Oh, probably way before that, 2012, 2013.
Okay. So
8 times a night, and
okay.
I've had it most of my life, actually.
Okay.
I was on Elmiron,
Okay. Wait. Okay, we're not going to talk about treatments. I'm trying to understand your body right now. So let me just ask questions, okay? This is what I do. If we were on the phone, and I'm sure I did with this with you 5 years ago, but I have to do it again. So, okay. So you have had symptoms most of your life. And your symptoms?
Well, no, as a young woman, maybe after I had the baby. No, you know what? Maybe before I had that. Well, I had a really super bad bladder infection since I was 19, and I had yeast infections.
Okay.
So yeah, I've had issues all my life with this stuff.
Okay.
Yeah.
So, and if you don't mind me asking, I'm Swedish and Norwegian. What is your background? Just out of curiosity.
English, mostly English.
Okay.
A little bit of Irish. Yeah.
Okay. Do you have super sensitive skin?
Yeah, I do. You were talking about the sensitivity, and I can relate to that sensitivity.
Okay. So can you wear wool on your skin?
Not if yeah.
Okay.
No, I can't.
Do you have drug sensitivity where you're prone to having side effects? So when you take a medication, you take a half dose or a quarter dose, you take?
Yeah, I've had some of that. Sometimes I can take smaller doses.
Okay.
Yeah.
Do you have a wicked sense of smell? Can you smell things that other people can't?
Yes, I have taste and smell things that I can smell.
All right.
Things people can't smell those.
Okay.
Yeah.
And would it be fair to say that when you were a kid, they wouldn't let you use bubble bath because your skin usually react to that? You had to.
I'd get hives or something. It would have, but I have used it.
Okay.
Yeah.
Okay. So you are, number one, a central sensitization patient. Let me ask you this. Do you have a sister or a mother or a sibling or even children who also have sensitive skin?
Not that I know of. I have a daughter. My mom doesn't, but she can't stand flowers, and she gets I have allergies too, which I think is part of the puzzle.
Well, it could be, but
she doesn't like flowers as a gift or something.
Okay, but we're really trying to talk about nerves here. So, would it be fair to say that you've been sensitive your whole life?
Yeah, I think so.
Okay. So you and I are like that way. So, and that's ancestral and that's genetic. So we have to, that helps us understand the landscape and the foundation of our body. You and I are wired to have a more sensitive nervous system. It is what it is.
Yeah.
It's not a disease. Yeah. It's just the gift of our glorious ancestors and how.
So yeah, my grandchildren have really blonde hair, blue eyes, and that strawberry blonde.
There you go. That's all.
That's us. Yeah.
So that's all we need to know. So I will tell you, for me, that I first had frequency urgency as a kid in 7th and 8th grade. I had my first food attack in elementary school when I made oatmeal cookies, and I got terribly sick from it. Bend over and scream or bowel cramping, as a matter of fact. Vulvodynia at the age of 18 or 19.
So what's vulvodynia again?
It just
That's the
feels like you have a yeast infection, but there's nothing there. Your skin looks normal and there's nothing to be found. But it feels like you've got an infection, burning pain. It feels like
I have that.
Yeah.
I do have that.
But do you remember
burning a little bit? It's kind of but it used to be itchy when I'd have a yeast infection when I was younger, but this is different.
So back then,
changed
right. So back then, they all thought it was yeast infection after yeast infection after yeast infection, and we should have had stock in and those over-the-counter, yeast creams, because God knows we all used a lot of them. In hindsight, now we know that vulvodynia for many of us had nothing to do with candida at the time. It had to do with sensitive nerves and tight muscles that were squeezing those sensitive nerves. So the odds are the reason why you had frequency urgency when you were younger is just because you had a more sensitive eating things or drinking things that were still. Or you and I would not have been able to get away with drinking caffeine like somebody who doesn't have central sensitization. So you might have just been tweaking out your nerves when you were younger and accidentally stimulating them. But now we have to deal with, does that make sense, Hannah?
Well, no, because I get all that white cottage cheesy kind of stuff that the doctor said was a.
Well, it's possible. If you took antibiotics, if you were eating a ton of sugar or carbs, yeah, you absolutely could have had yeast infection. I've had yeast infections a couple of times. But if we go back 30 or 40 years when you and I were younger, whoops, are you okay?
Oh, no, I'm having spasms and stuff here, and I'm not having a good time
here. Okay, so let's deal with where you are today. Where you just said you're having a spasm. Where is the spasm?
Well, my stomach gets all bloated and fizzy and bloating, and then it hurts down there, right? And then it's kind of a dull, sharp kind of pain. That's kind of
Where is the pain?
Down in it's right down, in my vagina, right? My vagina and my rectum, down in there.
Okay, so number one, we would be looking at the quality and health of your skin. That pain in the vagina is often due to dryness.
I should be taking Premarin again, I guess. And I've got another one that comes in tubes. And I forgot what it's called.
Somebody's already prescribed it for you, which means they already know you're
been taking it like a good girl. I just think it's not it. It's just
it isn't.
It would probably help. It's not going to fix everything.
It's not going to fix everything, but it's going to keep your skin moist. And it's going to help.
I'm going to do that tomorrow. I'm going to get that from the drugstore tomorrow.
And it's also going to help prevent infections, because when your skin is dry, you're going to be much more prone to having any type of infection. But when you give that skin estrogen, it produces mucus, which makes it harder for bacteria and candida to infect you. And so that's huge. So many women.
I don't get bladder infections anymore since I started having all this. I had one, and the doctor kind of made me take some. I went to the hospital, and he says, "You have a really bad bladder." But that was once, in like I used to get them all the time when I was younger, in my 30s, right?
Well, and remember, sometimes injury feels like infection, and it's actually not infection; it's injury. So okay, so I've got to wrap this up because we're going long. The stomach bloating is a whole nother story. That's not so. Are you feeling bloating when you eat? What's the connection?
Yes, when I'm bloating. They've done a colonoscopy on me and couldn't find anything. But yeah, it's after I eat.
So I want you to Google something called gastroparesis. GAS.
Oh, I had a book about that, gastroparesis.
and
I thought, yeah, I've got a book about bloating that was actually pretty good. I remember that word.
So gastroparesis is often found in some IC patients, especially central sensitization patients, because it's basically nerve driven. So when you have gastroparesis, it's delayed stomach emptying. It means that food sits in your stomach for longer periods of time, where it starts to ferment and produce gas. And then before you know it, your stomach just gets bigger and bigger and bigger. And then it can be agonizingly painful when you hit that point where you're starting to stretch the stomach. That's why I asked, are you belching or farting? If you're belching, that points to your stomach. If you're farting, that points to your bowel. I would hazard to guess that your stomach is involved to some degree. And if you could Google gastroparesis, gastroparesis, and just
ESIS. Okay.
And review the symptoms and see if they resonate with you, and then reach out back to your doctor and see if they think that you could have this. For gastroparesis, it's about smaller meals. And that's hard for me because I used to just eat one big meal a day. I can't do that anymore. I try to eat little small meals during the day. But it's also about avoiding foods that are hard to digest, that will sit
like
there.
Fats, I suppose.
Actually,
fats are hard.
Actually, for me, it wasn't fats. It was leafy greens. What kills me every single time is eating lettuce or spinach or kale. I won't do it. I get the worst gas in my stomach if I eat them. And that's so, as you read about gastroparesis and you look at the gastroparesis recommendations, what they're basically saying is eat foods that aren't as hard to digest, that will sit there longer, like an apple peel. They say peel the apple first, and so just read about that a little bit more, see if you think it might resonate with some of your bloating, and maybe send an email to your doctor or talk to your doctor about it and see if that might resonate with you a little bit. It's just a guess, but it's worth throwing out there. Okay?
Yeah, because the doctor did give me stuff to make it go through fast. And I guess all medications scare me because most of them don't work. All the things they've given to me
what did they give you? Reglan?
I don't know. I can't remember.
Okay.
I thought it started with an O or something. It's upstairs somewhere.
Well, make sure whatever it is, you research it, because there are a lot of lawsuits now about Reglan. They gave that to me too. And at about 6 weeks, the base of my tongue started vibrating. And and it can be irreversible spasm. So they don't recommend Reglan. What worked for me specifically, Reglan. What worked for me specifically was smaller meals and losing the leafy greens. Losing the leafy greens was just night and day for me, night and day. And so I've had, this summer, I've had 2 gastroparesis incidents where my stomach got really bloated, and holy hell, it really hurts. And I do the Gaviscon. Do you know what Gaviscon is?
Oh yeah, they sell that at the drugstore. Yeah.
So Gaviscon is way better than Mylanta and the other ones, because what happens is it puts foam at the top of your stomach that keeps the gas down. And so my dad has central sensitization. I mean, runs in my family. He and I are both avid Gaviscon users when we start feeling something triggering it there. And like yesterday, I was perfectly fine yesterday until I ate gluten, and then bam, I could feel feel things acting up there.
Yeah, I think I have trouble with a lot of gluten. I've tried to figure out from what I eat, and it just gets to be awfully complicated.
I know, but
it just makes my head spin.
But look at gastroparesis. Just take a look at that, read about that, and then start doing a few more lists. But they're giving you clues, hon. You're just not, you're not quite, you're resistant to their suggestions. I mean, they gave you the Premarin because, hello, you're dry and
Yeah,
all right. So
I forget about it. Yeah.
If it walks like a duck.
Well, maybe I've had some hope today because every once in a while, the doctor that I see a specialist for the pain, and he figures that I'm doing DNRS. I don't know if you ever heard of it, but it's a limbic retraining system. So you have to get into a better mood and get out of your anxiety, and then the body will automatically heal itself. And probably technically he's right. Like your body, if it's in a certain state, will heal, right?
Well, but you can't. That's not gonna treat aging.
Well,
that will do nothing for the quality and health of your skin. Your skin is drying like mine is.
Yeah.
That will do nothing to stop that.
Well, I think he's barking up the wrong tree a little bit on this because I have a little bit of hope here. I'm thinking, although I live in Canada, so it seems like we don't have all the stuff here that you guys have down there. It would be worth it. Maybe I'll email you. I'll maybe find out some more from the doctor, and so you can get to the next person. But thank you so very much. You've really been helpful.
You're very welcome, Susan. Keep in touch.
Thank you.
All right.
Okay, I will for sure. Thanks a lot.
All right. Linda. Hold on. Linda, I'm trying to unmute you. Linda. I can't. Linda, can you unmute yourself? There you go.
Me now?
Yeah. How are you doing, hon?
I guess with IC, there's always a state of frustration, and let's try this and let's try that.
Right.
And I'm going to try resending you an email. I tried emailing you. I just looked it up. It was September 2nd. And like you said, you do get inundated, so maybe it's buried. Because I tried to give you the whole background. But what the doctor has me trying right now is hydroxyzine.
Okay.
Yeah. And he told me to start with 10 milligrams for a week and then increase it to 2,
okay,
to 3 until I got up to 50.
Okay.
I'm taking them at bedtime. I'm taking 2 now. I'm on the 2nd week. I don't notice anything. I mean, I'm dealing with frequency and urgency, and the burning pain and broken glass is the feeling. I finished 5 weeks of physical therapy, and they've put in for additional ones, which I'm pretty sure have been approved already.
Did the physical therapy help?
Well, this is the 5th time I've had physical therapy over the 12 years that I've been diagnosed. And
Okay.
each physical therapist, I mean, I take or remember some of the stuff they have me do. And I believe it's helpful as far as learning how to relax the muscles and separate the Kegel drying up and then pushing out. It's almost like a birth sensation of pushing the bladder back in the other direction. Because anyway, I think the bladder physical therapy helps. What I've had in the last 4 years is hydrodistension with a Kenalog injection. When I've had them done, I've been pain-free for almost 3 months, except this last one in May,
Right.
which didn't give me any pain relief.
Right.
So it's frustrating because I'm always taking the Desert Harvest aloe vera.
Yeah.
And I just ordered, when I went on the website, they now have it with CBD. So I haven't tried it yet because I want to space when I try something new, because I'm taking the hydroxyzine now, and I thought I'd wait to see if that helps any before I try the
Well, so we have to remember mechanism of action, right? So we have to try to understand what we're trying to accomplish and what certain medications and or supplements could accomplish to help you. So I pulled this out because I wanted you to see this. So here's the bladder wall, right? So this is an example of the bladder wall, and you'll see we have a normal, this blue area is the mucosal barrier that keeps urine from reaching the cells underneath, right?
Okay.
Okay, so here's the normal mucosal barrier. It's not normally blue, it's just to make it stand out. And you can see that this acts as a barrier and it prevents whatever's in your urine from reaching into these cells. And inside below here, we've got blood vessels. So like there's a blood vessel. We've got nerves, and we also have mast cells. And a mast cells are throughout the human body. They're part of our defense network. When you get bitten by a mosquito and that mosquito injects a venom into your skin, the venom triggers the mast cell to release histamine. And histamine is what makes a mosquito bite burn. So one of the ways that we kind of used to describe IC is that it's like 100 mosquito bites at once in the bladder. So if you look at this picture, for example, and let's just say that everywhere there's a red spot, there's an injury. Now we know these are caused by the test, but let's just for reference purposes, let's just assume every red spot is an injury. So when this bladder fills with urine, urine goes into every one of those injuries. And so urine is now penetrating, you can see, down into these cells. So two things happen. Mast cells release histamine. So the reason why they gave you the hydroxyzine was to calm that process. So the hydroxyzine is a tried and true therapy. I did it for 10 years. And I loved hydroxyzine. I did hydroxyzine pamoate, not hydroxyzine hydrochloride. Hydrochloride is the pill, and also known as Atarax. Pamoate is in a capsule. And the pamoate is just a little bit purer than the pill for people who are sensitive. And I'm super sensitive. So that's the one they gave me. And so what that does is that just calms down all the mast cell histamine activity. And that's good. That's good. Dosage is up to the doctor. Some doctors go for a less is more approach. Some doctors go for a more is more approach. The dosage for Visceral was 25 milligrams. That's the lowest dose in a capsule. And they just had me cut the capsule open. So I was taking on average 12 to 14 milligrams when I took it at night before I went to bed. The side effects from Visceral, it's a well-tolerated medication. I mean, it's a very well-tolerated medication for most people. It can obviously can cause dry mouth. It can give you what we call hydroxyzine dreams, where it gives you more vivid dreams. So you might notice that your dreams become more intense. So a happy dream becomes the most joyful dream in the world. Okay, a medium sex dream becomes, oh my God, I'm having sex with 3 movie stars, which is what happened. I definitely had that dream a couple of times. And yeah, it was the cast of a Western, as a matter of fact. I forget who it was, but anyway. And then a nightmare can become a night terror. And it was about at the 10-year mark that I got night terrors from it. And that's why I stopped it. But it took 10 years for that to happen. And so just be attentive to that. If you start noticing nightmares, that it could be from the medicine. But otherwise, it's, AUA, IC step, it's a medication recommended in the AUA step 2. We have to ask ourselves, why is your bladder more injured or more vulnerable? And obviously, estrogen atrophy comes to mind. And so paying attention to the quality and health of your skin is important, because the drier you get, the more this happens, right? So when you use that little bit of estrogen vaginally, the assumption is that your bladder's getting some of that estrogen so that it can produce a bit more mucus. So that's important too.
Does the urologist prescribe
Sure.
estrogen?
Sure. Mine did. I didn't use it. I didn't think it was important because, again, in my brain, I was 25 years old, not 51. But oh yeah, he was the first one who caught it and suggested it. So trying to calm that. So we're trying to strengthen the bladder wall, help it produce a little bit more mucus, and the hydroxyzine is trying to help calm mast cells. It could be triggering some of that frequency urgency. Aloe is known for being kind of soothing, especially for urethral irritation. I mean, my experience working with patients is the ones with a bit more urethral irritation, the aloe can be a bit on the soothing side. The CBD is valid. I think it's worth a shot. Why not? As long as it's made well, and you can trust Desert Harvest Aloe. I think that they work very well with their ingredients. I think that they always are an organization that they're trying their best, and so the CBD would be interesting. But the one that I think would also be interesting would be on this one, the Aloe Path. So it's the same organic anthraquinone-free aloe, right? So the base ingredients are pretty much the same, but rather than using CBD, it uses PEA, and it's the palmitoethanolamide, which has been proven to calm nerve pain, and frequency urgency is driven by a nerve. And so this could be it. I mean, it's just 6 of one and a half a dozen of the other. You're just gonna, it's trial and error. But the hydroxyzine, that's a little bit over time. I wouldn't expect immediate results. The beneficial effect of hydroxyzine is that it also is very good at calming anxiety down. You get this very nice beneficial anti-anxiety effect. And then the aloe might be soothing, or the aloe CBD might help reduce some of that pain, but you don't have pain. You have frequency urgency, right?
Well, the pain is when I pee.
Okay. And
Aloe.
And where is the pain exactly when you pee?
My urethra.
Okay, so that's usually estrogen atrophy, right? That's the very first thing we have to consider with urethral pain is estrogen atrophy. And so, are you using any hormone products?
No, I'm 72. I haven't been off of any.
Well, that's probably the problem here. Is that as you age, you just get drier and drier and drier. And the urethra's the canary in the coal mine. It's the urethra that first starts screaming when your estrogen levels really start to drop. And it feels like there's a drop of urine stuck in your urethra that won't come out. And the urethra becomes very, very irritated.
Well, once I pee, I have no problem peeing.
Well, yeah, I know, but the point is that as urine is crossing through your urethra, it's irritating the hell out of your urethra because your urethra is probably quite dry.
During the night, the pain of the urine is what gets me up, and then once I pee, the pain is gone.
Okay, but your bladder depends on mucus, hon. Your bladder is estrogen dependent also. You need to Google genitourinary syndrome of menopause. Genito, Genito, urinary, URINARY, syndrome of menopause. I mean, I can see the frustration in your face. I can see that you are done with this. You want to be better. You know, I can totally see that in your face. We have to.
Before COVID, I know where every bathroom is, where anywhere I need to go.
Right.
Now with COVID, it's either got to be Walmart or Target because there's no access to bathrooms into the restaurant.
And that's scary. Walking in walking into Walmart or Target right now is pretty scary. Well, okay, so we always have to focus on potential causes first. We have to understand your anatomy first. And this is new for you. You've only had these symptoms for how long?
Well, the hydros have been working the last 4 years.
Okay, but you've been having these symptoms for 4 years. So they started when you were 70, right?
Well, I was diagnosed, no, I've had it since I was 62. It was in 06 when I was diagnosed, so I've had it for 12 years.
Okay, but you were postmenopausal when it started. Okay, so we always have to consider the role of estrogen atrophy in patients like you. For patients whose symptoms begin after menopause, our number one suspect is dryness. That portions of the bladder have become dry and portions of the urethra have become dry. And I think that what's making this picture complicated is that you're having results from the hydrodistension. So you're thinking, well, let's just keep doing the hydrodistension and whatever they're doing, except your last hydrodistension didn't work. The reason why hydrodistensions work is because they just break the nerves temporarily. So you feel better because they break the nerves, but the nerves always grow back. Well, we've got to try to figure out is why are the nerves exposed in the first place? And the nerves might be exposed in the first place because your skin is very dry. And so I think that what I would like you to do is read up on it, see if you've got any of the other symptoms that we associate with this, and then see if you can have a telechat with your doctor, a video chat with your doctor. So that you can begin this conversation of hey, is there any chance that we've just kind of missed the role that aging is playing on my skin? Because I suspect that you guys have missed this. I suspect that it could be playing a role. And so read up about it and see what they say. Okay, hon?
Yeah, one more question. When you were talking to the previous woman or the one before, I heard Epstein-Barr, and that showed up on my blood test last year. And what they said, you might have had it at what time? Is there any connection to that?
Well, we do know that they have found the Epstein-Barr virus in the urine of patients with Hunner's lesions. And so when he has gone in and done those hydrodistensions, did he say that you had Hunner's ulcers or Hunner's lesions?
No, they haven't said that I have Hunner's.
So then it's nothing to worry about. But you can ask him and just say, hey man, have you ever seen lesions in my bladder? Just out of curiosity. But I still think the biggest suspect is aging, hon. I really do. I just think your skin, because it happened to me when I was 52, and you're 20 years past that. You're 22 years past that. Your skin has got to be pretty dry down there now. And if your vulva is dry and your vagina is dry, so is your urethra. And it's amazing how quickly estrogen helps.
The physical therapists have me using a dilator, and I have the wand as well. I haven't used it yet, but the dilator, I've upped it to, I mean, they have small, medium, large, and then, oh my God, I'm like in the middle one.
Okay.
And I have to use a jelly to, I mean, it's painful, but she says I have to keep trying. And so.
Well, so remember that your muscles get tight in a response to pain. So the fact that you're doing something about that is good, because you've been dealing with this for years. You've had pain for years, or discomfort for years. So trying to keep those muscles healthy is absolutely the smart thing to do. I find that knowing where you're working is important. And so I would ask her, because, sometimes you just kind of get in there and somebody gives you a dilator or a wand and they don't tell you how to do it. It's like, okay, you stick it in, but you don't know what you're doing.
Well, I said 5 and 7 o'clock on the clock.
I know, but you still don't necessarily know how to move it, right? Because there's a movement that's involved. And so I've stuck my finger in through where your vagina would be. That generally you follow the muscle, you follow the length of the muscle. It's kind of a J shape, and you do that. And so ask the physical, but it depends upon which muscle group. Muscles are handled differently. And so make sure you ask your physical therapist to tell you exactly what movement you should be using. So mine said a J shape. And then also the other thing she had me do is, when I found a trigger point, to push on it for 5 seconds and release, and push on it for 5 seconds. And that actually was quite painful, because I was dealing with my post-surgical issues. And sometimes they will have you go horizontally across the muscle fiber, but just see if you can get a little bit more guidance on how to use your glass wand, because I think the glass wand would be more successful in trying to retrain your muscles and to try to help your muscles get back to their proper position than simply a dilator. But then I'm not the physical therapist, they are, but I think it's important for you to know how to move it. So see if you can get a little bit more guidance on that. Okay. All right, hon. Big giant hugs. You keep in touch and let me know what they say. Okay.
Thanks, Jim.
Okay. You're very, very welcome. Oops. Uh-oh. Okay. Ooh, Linda, I almost accidentally kicked you out of the room. I wasn't trying to do that. We're going to go to our last patient, Sierra. Sierra, I'm going to try to unmute you and see if you can unmute yourself. Uh-oh, hold on. Okay, you unmuted yourself and I clicked on it and I accidentally muted you. There you are. Hello, Sierra. How are you today?
Fine.
Fog?
Yes. Can you hear me?
I can hear you, and I'm just sending you a link right now to start your video.
Okay. Okay.
There you are. Okay, you need to move your phone a little bit back. Otherwise,
Okay.
we're getting a real good picture of your nose. Okay.
Okay, what do I have?
A little tiny bit farther back.
Okay.
There you go. All right, girl, how are you doing today?
I'm fine.
Well, you know what people say. When people say I'm fine, they're not fine. That's a secret code for saying I'm not fine.
Yes. You were telling me over the phone Friday when I called, you said that pelvic floor will help me in my OBGYN or my urologist can sign me up for it.
Yeah.
Because when I asked them about it, they said they couldn't do it. That wouldn't help.
Well, it depends upon if you have tight muscles. If you have tight muscles, they would always refer you to pelvic floor. If you're asking for a referral to a pelvic floor specialist for quote unquote your bladder, they're going to go, why? But if you're asking for a referral because your muscles are tight, it's like, okay, that makes total sense. So how did you frame it to them? And move your camera back, move your camera a little bit back. There you go. So how did you explain it to them?
I explained it to them through the IC, because I developed IC when I was sexually active, and every time I used to be intimate with my boyfriend, every time I used to have sex, it used to hurt really bad.
Okay.
Yeah.
And so your gynecologist would normally go, okay, that's interesting. What would be hurting? So normally a gynecologist would do a pelvic floor assessment to touch your muscles. Did they do that?
Every time I ask them about it, they say no.
Well, that's ridiculous. I mean, then one of the number one causes of pain with intimacy, especially at the moment when he's trying to come into your body, where he's trying to insert his penis up your vagina, if that hurts and that's tight, that is pelvic floor dysfunction, or we call it vaginismus. So how do they explain why your muscles are tight? I mean, how do they explain the pain with sex? What do they say? What's causing that pain?
No, then I always tell them every time I'm intimate and have sex with my partner, it hurts very bad. And they say that I probably was built too small or something.
Well, but if you're small, that means your muscles are tight. We're all told we're too small. If your muscles are tight, you're going to be small. So I think I would maybe push it a little bit and say, listen, if you think I'm small, we know that it might be because my muscles might be a little bit tight. Let me go have a pelvic floor assessment. Can you please just give me a referral so I can talk with a physical therapist to see if the physical therapist sees anything abnormal?
Okay. I'll go back to him on the 24th.
Good. I think there's nothing unreasonable about that request. If you've always had pain with intimacy, we have to ask why. And the reason normally why is because this patient has tight muscles. It's called vaginismus. There are some girls whose muscles are tight from childhood and they can never enjoy sex. It always hurts them, and they're afraid of going to the OBGYN to have their annual exam because inserting the speculum hurts because the muscles are tight. So it doesn't necessarily mean that you were born small. It means that your muscles might be tight. And so why not go see if somebody can check on it? I say push it, hon. And it may be that your insurance might not cover it. And if that's
let's cover the physical therapy.
Well, then what do we have to lose? I
don't know.
Well, you can ask your primary care doctor. Ask your primary care doctor if he'll make a referral so you can have a pelvic floor examination.
Because when I asked my doctor about it the other day when I went to have my 3-month checkup, he said he doesn't like go behind any doctor's back if they're already treating me.
But nobody's treating your muscles. He's not going behind anybody's back.
Yes.
Right? So what you have is a urologist who has not. I mean, did the urologist do a vaginal exam and touch your muscles?
No, the only thing my urologist do is like a urine specimen, and he put some jelly down there, and he like do an ultrasound of my bladder to see how I'm emptying out my water.
Okay, and when he put the wand into your vagina to do the ultrasound, was that painful?
No, that's not as painful as a pap smear. I getting tested for a yeast infection.
Okay. Well, I think that what you could say is that this has gone on for a long time and you want to follow every pathway possible. and you're just curious. I'd like you can say you've been doing your reading about IC and pelvic pain, and you're seeing that quite a few people do have long-standing muscle issues, and you just like to know what the health of your muscles are, and can he please give you a referral? It's a completely reasonable request, unless he's really, I mean, especially if he's taken any new classes on IC. Everybody's talking about the role of the muscles. He might be. Is he an older doctor?
Oh, my urologist?
Yeah.
He's about 40. She's about 40 something, 40,
Well,
50 something.
Well, and if the urologist won't go there, go to your gynecologist and see if your gynecologist would do a pelvic exam to see if your muscles are tight. I mean, any good urologist would do this at the very first appointment. I don't understand why this hasn't been done.
Yes, because I had it ever since 2005.
Yeah.
And when and my gynecologist, I told him how much pain I was in when he checked me for a yeast infection, because he saw my facial expression on my face.
Right. That's what they do. They look
Yes.
at your face when they're doing the exams, and that's how they can measure your pain level. Well, if I were you, I think I would try to go back to the OBGYN, whoever you're going to go see. Just, man, you got to be a bit of a pest at this point in time, and just say, guys, there's nothing unreasonable here. I just want to know if my muscles are part of the problem. I've had pain with intimacy for 15 years. Nobody's checked my muscles. I would like to know. Can you please give me a referral? You got nothing to lose. Okay. Okay, hon. Listen, we're running really long right now, so I'm going to have to shut down our Zoom meeting. Any last questions?
That is, I'm also on hydroxyzine, but I'm on that for my dry skin, and that's supposed to help IC too.
Yes. Yeah. Absolutely.
Oh, okay.
How much are
Okay,
you? How?
I just take one every night.
Good. Good. Have you noticed it's a little tiny bit harder to wake up in the morning when you take hydroxyzine? When I was taking it, it was like there was an extra layer of sleep I had to break through to wake up. But once I woke up, I was fine. But it was so what I did is I usually took it at dinner time. And when I took it at dinner time, it was easier to wake up the next morning. Have you noticed that?
No, because I never tried taking it in the daytime.
Okay.
Maybe I might have to try that.
Well, when you take it at night, can you get up early the next morning?
No, I cannot.
Well, that's the point. Is that if you take, rather than taking it right before you go to bed, you might be able to take it 2 hours before you go to bed, and that way you might be able to wake up 2 hours earlier. That's a challenge with the hydroxyzine. It's just harder to wake up when you take it.
What's the average milligram that you're talking about?
Well, let's go to here. Let's go. So let's go to this book. So Linda and Sierra are both on the same medication here. So let's see what Bob Moldwin said about dosage. So page 89 and 90. This is an older book, but it's still got some good references to it. Okay, antihistamines. Hydroxyzine is another medication that can significantly decrease the symptoms of IC. It's an antihistamine that, no. Hold on. Hydroxyzine is given in doses from 10 to 75 milligrams at bedtime. It can take anywhere from 2 weeks to 3 months to see symptom improvement. The dose of hydroxyzine usually starts at 10 and then is slowly increased at night over the course of 1 month. Hydroxyzine can make you a bit sleepy, therefore, like amitriptyline, can increase the duration of your sleep. It also has the same qualities as a muscle relaxant, which is often useful in the treatment of pelvic floor. And then it goes into side effects. So I never got above 25 milligrams myself. I mean, I always, but then I'm sensitive. I take lower doses. So I just found for me personally that if I took it right before I went to bed, I couldn't get up for 12 hours.
I'm glad you mentioned that because I did notice that I am taking it closer to after dinner than bedtime because I am slug in the morning. It's like midday before I have any energy.
Yeah, exactly. That's the way it is. So, well, listen, all right, ladies, I've got to shut down our Zoom because we're running long. It was great to talk to you both. Sierra and I have been talking for years. And Sierra, it's so great to put your face to your voice, and it's so nice to meet you. So you know who to call. I have got to go back to the Facebook and the YouTube chat. So I'm going to say goodbye to Zoom. You guys can come back to the other ones if you want. We're almost done for the day. So, all right. All right. The Zoom meeting is now shut down. I am now coming back to Facebook and YouTube. You guys learned anything interesting from those? Let's see here. I mean, it just shows you the rich diversity in this patient population. And it also shows you how easy it is to get overwhelmed because you're just looking for that one fix. You want that one thing to make it better, not understanding that there are lots of different elements that are contributing to all of this, right? Ina says more and more physical therapists and doctors think now that trigger points don't exist. No. We know they do. And in fact, not only in this book, what's really great about this book, if you don't have it yet, or Ina, I'm not sure how to pronounce your name, is that he has a whole section on the trigger points, and he tells you exactly where they occur. You can see I colored them. So he goes exactly through the trigger point locations. And as a matter of fact, these are my trigger points right here. I get these three trigger points right in my left butt cheek. Sometimes I get them up there. And then I get them in my left piriformis muscle. And I have not done, that's what I got to do tonight because I can totally feel things getting a little bit tighter down there. Uh-oh. Did I mute something accidentally? Can you guys hear me? I clicked something on my keyboard and I got a weird message. Okay. Eleanor is using a Theracane for trigger points. Power to you. I used a ball, a tennis ball or something like that. Okay. I don't know what book you're talking about. Lisa says, has anybody tried nortriptyline or amitriptyline? Amitriptyline, a low-dose antidepressant, can help calm nerves down, but they do come with a bunch of side effects. Dry mouth, dry eyes, irregular heart rate, which is what I got when I took amitriptyline. And nortriptyline, boy, that was impossible for me. It was like I was stoned. I was in a business meeting at my job, and it was like everybody was talking in slow motion with nortriptyline. They don't recommend anticholinergic antidepressants for people over the age of 50 because they are linked to cognitive decline. Cecilia says, my problem is my urgency at night. I get up 10 times to empty my bladder. I get so dehydrated in the morning. I was prescribed Myrbetrix and flavoxate. So Cecilia, you said you were on Elmiron for 10 years. Did the Elmiron ever help you? And I don't think that there's an audio breaking through chronic pelvic pain, guys. Cecilia, because they so many diagrams, I think they'd have a hard time doing it. I would happily record it for them. I should talk to them about that. So Cecilia, did the Elmiron do anything for you? Jennifer says, Cysto Protect or Cysto Renew? Does anybody have a preference? Bladder Builder right now is the top supplement because it has a pain fighter in it. And so the way that we're doing it is Bladder Builder, #1, Bladder Rest, #2, or for people who are more sensitive, and then Cysto Protect, Cysto Renew. But it's the extra ingredients of Bladder Builder, specifically the PEA, which make it much more appealing because it has the ability of potentially reducing some pain. But it's, it's trial and error. And luckily, there are a lot of things that you can try now. So if one doesn't work for you, then there you go. You can try others. Kelly says, is IC and neuropathy related? I'm having both and I'm at a loss. Where's your neuropathy? Jennifer, you can find all of those supplements in the IC Network store, by the way. We have them all. Jennifer says, pain is my primary. If pain is one of your primary symptoms, then the Bladder Builder really would be the first choice because it has a PEA in it. The only qualification for that is if you're uber sensitive to stuff or if you flare when you take a probiotic, then I would not take the Bladder Builder. I would maybe do Bladder Rest or Sister Protect with PEA instead, because then you... Okay, so Kelly has neuropathy in your hands and feet. Do they know why? I have neuropathy in my feet, but minor athletic injuries. I've had lots of steroid shots in the balls of my feet. Do they have a clue as to why that might be happening? Diabetes? Could you have diabetes? Something has happened to my eyebrows. You can tell I have not been able to have my eyebrows done. Oh, they look terrible. Ah, such is life. Any clue why you might have the neuropathy? Have they given you any hints at all? Kelly? Ravonda says, you wonder if PEA can interact with other medicines? Hun, you can go to the National Library of Medicine and look at all the other research studies like I did. And honestly, I found very, very few side effects. I don't know about interactions, but it was extremely well tolerated in the great majority of patient studies. But I encourage you to go to pubmed.gov and type in palmito oil ethanolamide. You go to our website, get the spelling, and just take a look at the other studies and see what they say. Kelly says, mostly at night, you've been to the urologist, you had a full blood panel, no other issues, but was diagnosed with IC, but you have neuropathies. Joan has neuropathy in both legs and feet. Do you have do you have any foot problems anyway? I mean, do you walk normally? Is there anything weird going on with your feet? Andrea on YouTube is asking about estrogen. It's normally estradiol, a compounded estradiol cream. Huh. Well, I think you might need to go see a neurologist to see if they can help you figure it out. I mean, neuropathies don't come with IC in general, but they can happen with a pudendal neuralgia or a major injury. But if you had, if you suffered some sort of major trauma, then a neuropathy makes sense. I don't know, hon. You're gonna have to talk with this all started in May and was never an issue with my feet at all. Kelly, how old are you? Estradiol, estradiol. You've had what? Okay. Yeah, they can. Okay, so Ina makes a good point, and this is really interesting. So when I was in my 20s, and I was dealing with IBS and vulvodynia, not IC then, just these weird other things, which I now understand are mostly related to other stuff, like my muscles. I had something very weird happen. The bottom of my feet started to tingle when I needed to have a bowel movement. I was literally like laying on my couch reading a book and my feet started tingling. It's like, what the hell is this? And it was kind of scary. It's like, this is so weird. Why are my feet tingling? This makes no sense. And it took a couple of times before it's like, oh yeah, look at that. I ended up going to the bathroom like 10 minutes later. And of course, when you consider the proximity of, I wish this had nerves so you could see the nerves, but if the proximity of the nerves coming off of your spinal cord with So let's put this together again. Wait, I gotta put my vulva. Where's my levators? My vulva. Okay, so hold on. Actually, technically, it's a levator. So if we put, oh, come on, these magnets are not very good. All right. So look. So we put in the uterus. And then look at this. The bowel goes in behind that, right? So look, so we've got the uterus and we got the bowel. Well, here's the problem is you got nerves that are traveling right next to the bowel and right next to the other tissue. And that's what was happening for me is that as something hard was moving through my bowel, it was pushing on the nerve, which was making my feet tingle. And it still happens today every now and then. Every now and then, if I'm not eating enough fiber and things get a little bit hard, like you're trying to pass marbles, that's when it's so hard, it's starting to push against nerves. And so number one, the feet and the pelvis are connected neurologically. And number two, pudendal neuralgia. If you've got pudendal neuralgia, then you could also have, it all kind of makes sense. Joan says her pain increased after bowel movement. See, everybody's different. It's fascinating, absolutely fascinating how this works. Kelly, listen, you are an anatomical mystery to be solved. And I think that the hand neuropathy is interesting. The foot neuropathy is interesting, but you're really going to have to talk with a neurologist to try to figure it out. Like, I also have a essential tremor. Essential tremor is what Katharine Hepburn had. And so if you remember Katharine Hepburn, as she was getting older, she, her face was moving like this and she would have trouble talking. I have that exact same tremor. But it only really shows up if my neck is really tight. But sometimes when I'm doing these, you can actually see my face. I'm just starting to do like a little bit of that. So I don't know. That's just something that sometimes we inherit. So it would be interesting to see if you inherited anything funky. I don't know, hun. I don't know. Andrea says, Jill, you give me hope. Thank you. You are very welcome, Andrea. If I've given you hope today, then my job is well done today. That is my goal. All right, guys, last call for questions. We've been doing this for 4 hours. And my back hurt my back yesterday, so I need to get up off of this chair. So last call for questions, last call for questions. Otherwise, I'm going to give you your homework for the day. Number one, if you found this helpful, would you please come on over to the IC Network and maybe sign up for our free newsletter, or better yet, become a member so that you can get our wonderful magazine, which I pour my heart and soul into with our writers. We've been doing these for 18 years, and this is how we give you much more detailed information. Don't forget also, September is IC Awareness Month. Your poster is on the back of the current issue. You can cut this off and you can put this anywhere. Give one to your doctor. Why not? I know it's a little late and this year is different. It's hard to get a lot of energy behind IC Awareness Month when we're dealing with Ruth Bader Ginsburg's loss and all that other stuff. Oh, woman, you were such an inspiration to me. I wish she'd been able to hold on for another couple months. What a year, my friends. What a year this has been. Please vote. Register early because we know that we cannot stand in a line for a long period of time. And so vote early, and please, I try not to bring politics into it, but we have to this time because our Social Security benefits are deeply threatened now. I started the meeting talking about this. Your vote has never been more important than it is at this very moment if you rely on your Social Security for disability or retirement, because the president has suggested that he would stop the payroll tax that funds Social Security. The Social Security actuary has published a statement stating that if he does that, all Social Security disability benefits will end next year because they will run out of money, and all retirement benefits will end in 2023 because they will run out of money. That is the truth. I have a link on our website. And if you need your Social Security, then you need to vote blue. The second issue is, regardless of what he says about covering pre-existing conditions, they have a case in front of the Supreme Court the week after the election to get rid of coverage for pre-existing conditions. It's California versus Texas. It is on the Supreme Court calendar. If you want coverage for pre-existing conditions like IC, vote blue. Vote early. Tell everybody you know who relies on benefits to vote. I don't want to be political, but my future depends on this. Because I don't have a retirement fund. It's what I save. And if I ever sell the IC network, any money I might get from that. That's it. And it's hella scary to think that I might not have retirement benefits that I have paid into. Because this is not an entitlement program. This is pulled out of our paychecks. And to think that could cancel our paid for benefits is infuriating. And I hope you share my fury. And for anybody who's had pre-existing conditions, to think that a health insurance company could charge us double, triple, quadruple for coverage, or worse, refuse coverage if we lose a Supreme Court case. Guys, we're past anger. This is about action. And if you live in Kentucky or any of those swing states, you've got to vote and vote blue. If you want to protect your insurance coverage and your Social Security, you have to do that. If you don't, then you're part of the problem. Please vote and help other people vote. Get them there. And the whole Ruth Bader Ginsburg thing, I mean, seriously, 3 years ago, 10 months before the election, Mitch McConnell would not allow Obama's choice for the Supreme Court because he said the next president should decide it. So 10 months early, they refused to even interview and vote on Merrick Garland. And then Lindsey Graham goes on record and says that will never happen in 2020. He would never allow that to happen. And what does he say today? He says, oh no, there was never a video. I never said that. They have him on video. They have him on video. He was in he was in a Senate hearing when he said it. And now those guys are saying, oh, no, that's only for Democrats. For Republicans, we can do whatever we want. So, yeah, we're already voting. And we can still put somebody. We're not going to wait for the next president to make that decision. Well, screw them. It pisses me off. I'm sorry. If I was a Republican for years. But this is not the Republican Party of Reagan. It's a disgrace what's happening right now. Whatever happened to ethics and values? These are about powerful people who want to stay in power, and they're going to push the rest of us down. Did you see yesterday that there was a group of Republicans trying to prevent Democrats from voting in Virginia? Vote. Vote. We need to take our country back. You as a disabled patient, you as somebody who's going to get older, you need your benefits. And believe me, despite what they say, actions speak louder than words. There is a Supreme Court case, California versus Texas, that is going to repeal Obamacare and pre-existing condition coverage. And there is no replacement plan. Nothing. He says there's a plan. He's had 3.5 years to publish a plan. There is nothing there for us. Nothing. Vote. Vote. Vote to protect yourself. Vote to protect the IC community. And honor the legacy of Ruth Bader Ginsburg, because she asked, her dying wish was that they would wait until the next president was sworn in. And those, it breaks my heart what's happening right now. I can't believe it. I cannot believe what's happening right now. Vote. Vote them out. Vote them out. One thing you can count on is that Joe Biden is not going to cause a veteran a loser. He's a patriot. It doesn't matter if you're Republican or Democrat. This is about country over party. If you want this country to survive, and if you believe in we the people, and that everybody matters, and that the disabled matter, and that women matter, and that every race matters, vote. Vote. And vote blue. All right, listen. I don't think we can't take anything for granted. Every single, because that's what they're already doing. What they're already doing right now, Trump has, and the Republican National Committee have massive attorneys, and they're going to all the swing states, all the counties, and they're already challenging them on absentee ballots. They're already doing that. They're getting ready to fight to exclude your vote. And the Democrats are now trying to have their attorneys get in to counteract that. All you can do is get your pen, get your paper, vote, walk it in, make sure it's counted. Okay? We deserve better. And won't it be nice? I told everybody on my birthday, I said, listen, no party for me. We're going to have a party the day after the election. Hopefully. All right, guys, I'm going to leave you with that. Donna says, don't be sorry, Jill. I agree 100%. And I'm in Virginia. I get it. Yeah. Man, you know what? Fool me once. Shame on you. Fool me twice. Shame on me. Hopefully people will not be fooled twice by this idiot. All right, guys. I'll talk to you later. Have a good one. Sorry to end it that way, but it's the times. Hopefully in a month, we will be able to celebrate. And believe me, we will have a party online. Okay. Talk to you later. All right. Bye, Donna. Bye, you guys. See you later.